Why are you hiding it?
Go ahead.
Why are you hiding?
I welcome everyone. It's 4:55. We have all our panelists already online, and today is a first among the series of minimal invasive spine surgery webinars. We are going to have many more coming up in future on MIS as well, seminars and webinars on MIS. This is only one form of minimal invasive spine surgery that we are all going to discuss today, which is tubular minimal invasive spine surgery. And among the panelists, we today have a big panel of some of the very, very prominent, famous, and people who are having humongous volumes and experience into minimal invasive spine surgery. We have none other than Dr. Arvind Kulkarni, who's very, very senior member of Minimal Invasive Spine Surgeons Society of India, also called MISAB, or Minimal Invasive Spine Surgeons Association of Bharat. It's a registered body of minimal invasive spine surgeons across the country, with surgeons from various fields of MIS, including tubular surgery, endoscopic surgery. And currently, Dr. Arvind Kulkarni is the secretary of MISAB. I would, on behalf of MISAB, urge you all to visit the website of MISAB, Minimal Invasive Spine Surgeons Association of Bharat. There is an annual conference coming up in October discussing on various aspects of MISS. Also would urge you all to try and become members to be a part of this largely growing, fastly growing fraternity of minimal invasive spine surgeons of India. Another very senior panelist with us today is Dr. Vishal Peshattiwar from Mumbai. Has got huge loads of volume of experience in degenerative spondylolisthesis and high-grade spondylolisthesis. We also have, Sai, may I request to please put everyone else on mute, please? I will unmute myself. All the participants, may I request you all to please go on mute mode. It is for the benefit of the webinar. We have with us Dr. Ayush Sharma, who is another MIS surgeon from Mumbai. Dr. G. Balamurali from Chennai, another neurosurgeon. And we have Dr. Amit Sharma. He's another MIS surgeon from Mumbai. Dr. Neeraj Vasavada from Shalby Hospital, Gujarat, Ahmedabad. Dr. Gururaj Sangodimath from ISIC Delhi. He's been giving us a hand in most webinars so far. We have Dr. Umesh Srikantam, another neurosurgeon, to add to the perspective of neurosurgeons in MIS surgery in spine. He's from Bangalore and has huge volumes, not only in neurosurgical spine, but also in spinal tumors. Both Dr. Balamurali and Umesh Srikantam will add to the flavors from neurosurgeons' point of view. And we have none other than Dr. Ranjit Unnikrishnan, who is huge volumes in MIS deformity corrections, who's going to join us today. So let me welcome all the panelists. I hope all the panelists are with us already. This webinar is also being relayed on YouTube and also on Facebook. So people who feel their internet bandwidth here is getting disturbed, I would request and urge them to please go on Ortho TV or YouTube. I would also like to bring to the fact that Ortho TV is exclusively running this show on all social media platforms, YouTube, Facebook, and also on Zoom TV and Ortho TV. I would request you all to please also propagate the message to people who would want to be a part of this webinar. We are going to be discussing upon various aspects of this minimal invasive spine surgery. And today we have primarily got tubular MIS surgery as the focus for all of us. And we are not going to discuss about other issues. Again, to set the the rules of the game, all participants on mute mode unless they have a specific question to ask. Our panelists will be there to take your questions on the chat group. They will answer on the chat group also. We will share the articles pertinent to that point of discussion right then and there in the chat group. You can download them. If you miss upon them, don't worry. Dr. Sai Jyot Raut, who's the host of this platform, will send across these articles to you. Try and keep your video also on stop mode. On the extreme left of your screen, there is this stop video. Please try and keep the video also off so that the bandwidth is uninterrupted and we can continue our discussion for a long period of time. We'll be starting in 2 more minutes from now. To bring about the overview of today's webinar, we are going to talk about principles of MISS surgery. We're going to talk about various types of MISS surgery. We're going to talk about where, like a beginner would want to start his MIS surgery from, which is like the indications of MIS surgery. We would also want to speak and discuss in detail about when not to do MIS surgery. We're going to speak about the learning curve and early problems that one can learn from the masters present in this scenario and try to avoid those problems. We'll also be speaking about the basic requirements before you start MIS surgery. We'll also be talking about various surgeries in MIS, which means microdiscectomy, MED, fusion in the form of MIS TLIF, also OLIF, and percutaneous pedicle screw fixation. We're going to talk about problems in MIS surgery, and of course, the bigger giant of problem, radiation in MIS surgery, will also be discussed in detail. Dr. Arvind, are you there?
Yes. Hi.
Hi, Dr. Arvind. And we have Dr. Vishal Peshetiwar with us already. Dr. Vishal Peshetiwar.
Hi, Vishal.
Hi, Vishal. Welcome. I can already see Neeraj, Umesh, and Ranjit. Welcome you all. Let us start with our first slide, or maybe let me have an opening comment from Dr. Arvind Kulkarni. Arvind, would you like to put up an opening comment for MIS surgery? I mean, you started your work in KEM Hospital way back in 2005, and since 2008, you have been doing MIS surgery. You have seen the evolution of MIS surgery right from the inception of MIS in our country. Your word on that, please. Opening comments.
Yeah, thanks and congratulations for organizing this particular theme for today. You cannot escape minimal access spine surgery anymore, and everyone now is a MIS surgeon. So when I started, there were only two sets in India. One was with Amit and one was with Dr. Jaiswal in Delhi, and this was the Matrix 1 system where you used it with the endoscope. And we bought the first one with the which is compliant with the microscope, that is a Matrix 2. So that was when there was a lot of skepticism and cynicism about MIS, and we have that is in 2007, and we have traveled a long distance since then. So about 12 years, we have every hospital has now a MIS surgeon, one or two MIS surgeons. The number of microscopes that have been bought all over India have been increasing. More and more orthopedic and spine surgeons have been using microscope, and patients have been asking for MIS. I mean, you don't have a single patient in the learned population who wouldn't request, even if it is a case of scoliosis, they won't hesitate to ask you if it could be done using MIS. So that is the penetration of MIS in the society, and obviously it is not for any a thrill or a gimmick point of view. From a gimmick point of view, it definitely makes a difference. I would be very hesitant to do an open surgery in a elderly lady with hundreds of comorbidities, who is obese, who has a high BMI. It is a crystal clear indication for doing a MIS, and I have seen the society also is increasing in numbers in terms of enthusiasm. We have all seen how successful our workshops, our annual workshops, whether it is in Bombay or Bangalore or Delhi, wherever. So good. It's going in a very vertical trajectory.
Perfect. I think a brief about MIS right from its days of evolution, where we started, and now we have Dr. Vishal Pesheti. Or Dr. Vishal, you are in the most advanced systemic systems of MIS today. What do you see? What is new in MIS today? Today, where like we started with those bigger tubes, now we have narrow tubes. But what is new about MIS today?
In India, at least, the next frontier is going to be doing deformities via MIS and doing more and more difficult deformities like high-grade lysis and adult degenerative scoliosis.
So the indications are growing up.
Absolutely. Revision surgeries. It's like training. Whenever you start, you probably start with a discectomy, move to decompression, then go to fusions, then go to multi-levels, and then scoliosis. That's the natural training in a spine surgery fellowship. I think MIS is the same thing. As you do more and more, you realize probably you can push the envelope a little bit more.
And all this is possible purely because of increasing surgical skills, or the technology associated has also increased now?
So it's like, see, you cannot give a taxi driver a Ferrari to drive in an F1 circuit. You have to train yourself to reach that level. Nobody is born with skills. They have to be acquired. And with collaboration, it goes ahead. So, I mean, what I was doing 12, 13 years back and what I'm doing now is definitely different. The indications have changed. I was very hesitant to do 2 levels in 2007 and 8. Now I am hesitant to do an open surgery for anything, unless I have to remove the old implants, which requires a midline incision. Anything probably can be done in MIS.
I think very pertinent that the indications have grown up, the surgical skills are growing up. Like Dr. Arvind mentioned, there are far more number of workshops happening. The interest level is increasing, and of course, the technological part has increased now. We have with the advent of OARM, with the advent of navigation, with the advent of modern implantation systems, with the advent of newer diagnostic modalities. with better intra-operative environment, with newer imaging modalities available, better C-arms available. I think the understanding about MIS and the other avenues of MIS are getting better and better. And I'm sure the future of MIS is also very, very bright. Let me catch Dr. Ayush. Ayush, you are the youngest of MIS surgeons in the fraternity. What do you see as the future? Like, how do you head from here in 5 years? What is the path that MIS is going to take from here?
Even for me, every year you grow. I know as I do more and more cases, the blanket of my indication is growing every year. I see doing the things which I never dreamt of doing as a MIS. Even now, we can tackle things where open surgery was challenging. A patient who had a posterior instrumentation, you want to go in, I will rather go any day MIS than do a revision open surgery in them. I know I am safer, I am better when I do this. And so we every year, every day, we are expanding the blanket. Now, I think in future, we should be able to do anything and everything with MIS. It is just a matter of time. With the technology, our confidence and the skills, once they come together, there should not be any case which we should not be able to tackle with MIS in future. That is how I
think
see
the message, if you heard all the three guys, they have been very, very clear that MIS has been evolving, and with each growing year, not only the indications are getting better, the results are improving, the technology is helping us to get better results, and it's a very established thing, and the future is very, very sharp and bright, and nobody will be able to escape it, not because it's something that we are trying to promote here, but it is because it is something that is of advantages to the patients for very obvious reasons. Laparoscopy also took the same path. Initially was resisted, but now is a very established standard in abdominal surgeries. In the same way, MIS initially had a resistance, has been taken up by many, many surgeons. The senior most guys in the city and country are doing it now, and I'm sure the junior most guys are learning it faster, and there are plenty of avenues. So we know the advantages. Ranjit, for the sake of delegates, can you please highlight what are the advantages of and why is MIS at par or better in terms of open surgery? Why? Ranjit, what are the advantages of MIS surgery in spine? Ranjit? Neeraj, can you take up that question, please? Neeraj? I think Neeraj and Ranjit both are missing from here.
Vishal, can you hear me?
Yes, Ranjit, can hear you better. Yes.
Yeah, yes, Acha. There was some snack here. Yeah, I mean, like you rightly said, like arthroscopy is for an orthopedic surgeon, MIS is for a spine surgeon. Eventually, we all have to know it because definitely it has got better outcomes. So I think in our thought process, we should first try and see that is this particular surgery, when indicated, possible by MIS way? Can I handle it well? If yes, go ahead. If not, go and learn how to do it.
Right.
I think that's where we should take it.
So what are the advantages you see are like, for example, if we are doing a degenerative spondylolisthesis, we know that the gold standard has been a posterior lumbar interbody fusion or a transforaminal lumbar interbody fusion. So what are the advantages that MIS adds to a conventional open surgery?
Well, number one, apart from the so-called morbidity and decreased hospital stay, decreased pain, I think the safety for the surgeon and the patient, because of the better visibility, the illumination and the clarity itself gives a lot of safety for the surgery, right? Apart from all the so-called advantages, low hospital stay, and today I think so-called increased cost is no more valid. With enough systems available locally, the one of those obstacles for MIS was increased cost of equipment. No. And also learning MIS with the MISAB and all, having so many meetings, I think those both are not anymore valid.
Right. Arvind, you have been a open surgeon also for a short period of time in your early career days, and now you exclusively do MIS. What are the advantages that you have perceived and are able to convince and believe upon that these are the advantages that I cannot not offer my patients now? So obvious advantages of MIS. Clinical advantages.
No, in fact, see, I started with the tube. My first case was with the tube. This was a demo set which was traveling all over the country. There was only one set in India, and I started with it. So though I just started my career, I invested and bought the set as ASAP and started doing it. So while doing it, I can tell you, so I've been extending my indications, the so-called complex stenosis, wherein you need to instrument in so many cases, situations. I don't instrument them. I'm quite happy with the patient's outcomes. I've extended my indication in terms of complexity when it comes to fusion. So from from degenerative to lytic listhesis to, in fact, we did a case recently which had spondyloptosis, which is even so complex to do open. So most importantly, I love to do this because the surgery is very elegant. There's hardly any, you're not tearing the muscles apart. There's no blood in the field. It's a very clean and elegant surgery. You go in and come out, and
I think all the speakers have brought it very correctly. The advantages of MIS surgery are very clearly known to all of us. It is not about the size of skin incision. It is not only about a small incision. It is about reduced morbidity. It is about less blood loss. It is about enhanced safety to the patient. It's an elegant surgery. And the most important part, like what Dr. Arvind and also Dr. Ranjit mentioned, is the muscles, the collateral damage that happens in open surgery, the muscles which usually are retracted, get fibrosed, all these problems, the muscle damage happens pretty less in MIS surgery. And I think that is the principle of MIS surgery. And we all must understand that the principle of MIS surgery is not to bring the size of incision down. The primary principle of MIS surgery is to reduce the collateral damage. And it's not only one way. Tubes are only one way of doing it. There are plenty of other ways of preventing the collateral damage of a conventional open surgery. And there is absolutely no fight, no argument, no comparison to conventional surgery. There is no argument to say that conventional spine surgery is also, it has served the test of time. It has lasted for more than 100 years now. It is doing wonderful. And in fact, all the MIS surgeries are trying to match upon to the results of conventional surgeries. And in many indications, I think MIS surgeries already surpassed the outcome of conventional open surgeries. However, yes, they are good, but MIS surgery is also catching up. And the first thing that we may understand, we must follow this principle that the collateral damage of open surgery has to be brought down. And that is the primary principle of MIS surgery. Dr. Vishal, your take on that? Is it the use of tube that makes it MIS, or is it the use of endoscope that makes a surgery MIS? Or there are surgeons who, in fact, using a tube have been creating more damage. Can you elaborate on that, please?
See, the whole idea of the message of MIS initially was it's a cosmetic surgery, and that's all it was restricted for. I did the first 8 to 10 years of my practice as an open surgeon, and subsequently, the past 14 years now, I'm doing minimal access. The difference has been, of course, the morbidity. The size of the incision, if you look at it, a midline incision is much more cosmetic than a minimal access incision, which will be like several small holes. But the advantage is there is no denervation of the muscle. There is no physical loss of muscle volume. Second thing is the amount of pain that the patient gets because of less tissue handling is much less. Other thing is they start walking early. So the physiological loss of stamina, as people used to call it, the physiological capacity loss is very less when you do a minimal access surgery. It can be in any way. It need not be tubular. In fact, I think even tubular surgeries are going to be outdated in a couple of, in a decade or so. We're going to move towards endoscopes and more towards flexible endoscopes. And as instrumentation changes, we are going to go through memory rods and all that. But that's beyond the scope of this meeting. But minimal access, the principle of minimal access is to try and do minimum access trauma to reach the pathology. We grew up where our teachers used to teach us that big surgeons have big incisions so that everything is in front of you, you see everything clearly. They fail to understand the amount. It's like if you're doing a laparotomy to take out an appendix or a gallbladder, it's very easy. It requires very little money. But the damage caused to the abdominal wall, to the intestine going and adhering there, it's not just the access trauma at that time. It's the trauma that the patient undergoes throughout his lifetime due to damaged muscles, due to adjacent level. Muscles also control the adjacent level. The moment you open that much up, the next level also has some amount of stress. There's a paper of 2011 which shows this, that the moment you do midline access, the adjacent level stress increases. So minimal access surgery is more like a minimal damage while doing the surgery. It can be in any way. There are some people who have adapted midline because paramedian incisions weren't comfortable for them. That's a way of doing it too. They call it hybrid. I mean, all of these fall in the gamut of minimal access. You have to choose what is good in your hands, what is safe in your hands. If you think tubular is not okay in your hands, please don't do it. Go back to conventional open surgery. But then you're going to be a dinosaur at some point.
Right, right. I think Neeraj, in a chat group you mentioned about another advantage of less infection rate. Would you like to elaborate some other advantages of MIS surgery over conventional open surgery?
Major advantages has already been described by Arvind and Vishal and other people. I think, that was one which was missing, which I significantly noticed. I offer MIS to my patients, solely because of two purpose. Of course, muscle damage, I would say, muscle damage, early recovery, all the things I would say is an ancillary kind of a thing. Important, significant reduction in blood loss, which doesn't change physiology of your patient post surgery. And second is, I think I have almost zero infection rate in any of my MIS patient in last 12 years. Open is still, we have 1.52% infection rate. I've yet to see almost an infection in MIS. So that's, for me, it's a very, very, very significant advantage why I would offer MIS to patients.
Right, right, right. Yes, Dr. Ayush.
Yeah, so Vishal, one thing, mine is a government setup, okay? And we have changed completely in last 4 years from being a open driven spine center to a completely MIS center. And recently we reviewed our data from open surgery and MIS surgery, and we have around 400, 450 degenerative cases. And the most interesting thing which we saw, which never gets talked about, is return to work. The patients who underwent MIS surgery, they return to work much early. It makes a lot of sense for a center like me when most of the patients are employed. That is how we have been able to convince the administrative authorities that it really works, and that we should be able to present soon. It was one of the papers in Spine Week, fortunately got cancelled.
Yeah.
But
I think it's a very pertinent point. Another thing, Dr. Arvind, I have seen one of your paper about dural leaks. I think you mentioned that MIS is far more forgiving. Would you like to please open your comments on that?
Yeah, this is real. Yeah, so see, when the tube that you insert, it is there for a temporary stay only. You're not creating space. You are actually using a potential space which is going to collapse after the tube is removed, after the port is removed. So the soft tissues fall in place, and it's such a good tamponade that if there is CSF leak, and if you take an intermittent stitch, deep stitch, there's very low likelihood of getting a CSF leak. So if you compare it that with an open surgery where the CSF keeps flowing out like water from a bucket, here it is an inverted cone. So the possibility of you developing a CSF leak postoperatively is the chances are bare minimum, because there's hardly any dead space. There's no dead space. It all shrinks in size once the tubes are removed.
Right, right.
I hope
so,
got the...
Dr. Bala Murli, Dr. Bala, are you there with us? Hi, Bala.
I am.
So we would like to hear from you. Welcome, Bala. Yes, you just joined us. So while you set up things, Umesh and Bala, as a neurosurgeon, do you feel that handling of dura is a challenge when you do it with tube? For example, having more dural leaks has been a concern mentioned in literature, at least in the earlier part of your MIS surgeries. And then having dural handling or neural injuries has also been a concern in the early part of your career. Like in first 50 cases, would you have some concerns for your younger guys taking up tube surgery in first 50 cases? And if yes, how do we reduce that?
Yeah, so a couple of things. One is it depends on what you're doing the surgery for. If you're doing for a discectomy and you have an incidental dural tear or a TLIF or whatever, through tube. As Arvind very correctly mentioned, the dead space collapses is never a problem, either with open, especially with MIS, it's never a problem. And even in my first 50 cases, when I was initially learning and trying, I don't think I've actually experienced any of that problem. Now, the other category of thing is patients who we actually do intradural procedures for tumors or for any intradural procedures where you make much more bigger opening. Even in those cases, I have not actually come across a significant increase compared to the same leaks you would get even with an open surgery. If you have an incidental dural tear with an open surgery, you can still have, one in few, 100 patients who would still have a leak despite very good closure. So, for the younger generation, what I would say is that, dural leaks, whether it's incidental or you're opening for a tumor with a tube, does not have an increased incidence if you have a good closure. And you should not be, weighed off by thinking that though the literature does say in your initial curve of your experience, you may develop more CSF leak related problems with a tube and neural injury has been quoted. In my own experience, I think it's not the case. And in most people's experience, it's not the case.
Right, Umesh, would you like to tell us about your experience? We are talking about the advantages of MIS. We have elaborated a few of them. I'm sure you heard few of them. The concern we are discussing that in an attempt to have these advantages of MIS surgery, sometimes we may come across problems of neural handling, dural leaks. In your practice, in first 50 cases versus next 50 cases, was there a difference in dural leak and neurological injuries?
Well, Vishal, see, first, if our principles are correct, then I don't think there should be an increase in the incidence of dural tears, as Bala has already mentioned. So you see, the dural tear is not because we are operating in a tube or because there is reduced visibility. It is when we are using our instruments in a wrong way. Like, say, for example, we catch the dura when we are using an upcut or something like that. So this can happen increasingly in a tube if you don't have the correct visibility. That is, if you try to put your upcut where you're not visualizing the dura and then try to remove it in that case. So that is why it's always better to have a clear visualization, even in a tube. Our tube is not a stagnant tube. So we can move the tube above and below, and then accordingly, we can actually visualize the area of the, like, say, for example, in a UBF, we have to visualize the upper border of the lower lamina. We have to go there. And when we are resecting the attachment of the ligamentum flavum to the upper border of the lower lamina. So it's very important to visualize that area before we insert any instrument there and cut off the ligament there.
Right,
so
right. I think very valid point. Very valid point. And I think all the speakers have very categorically mentioned that the indications of MIS have been growing up as they are evolving. The MIS technique and technology is evolving. The indications are getting better. The results are getting better. Yes, there are early concerns. However, these concerns can be addressed best if you follow the basic principles of tubular MIS surgery. And the principle of MIS surgery is not to do a suboptimal decompression or to jump into a particular surgery when you are not skilled about it. You can do decompressions, you can do fusions, you can do fixations, and all these three things can be achieved by reducing the collateral damage. That is the basic principle of MIS surgery. We are not going to talk about what are the other advantages of MIS surgery at this point, but we all know that less pain, smaller incision, less blood loss, less infection, more forgiving, less problems even if you have a dural leak, because the vacuum space left inside for a pseudomeningocele or CSF to collect is very less. So it's less problems with even dural leaks also. And also, of course, early return to work, less physiotherapy requirement are all obvious advantages of MIS surgery. And all these can be attained purely when you follow the principles of MIS surgery. We all know that there are various types of MIS surgeries. Yes, please.
Yeah. I want to make, just when we are discussing about dural tear, I want to just make one more point. So,
Umesh, we have full list of complications and problems we are going to discuss about. The whole idea of bringing this forward is that there is a concern about in people's mind that MIS means less work. The answer is no. In an attempt to get all the advantages, the work remains the same. The only thing that gets changed in a MIS surgery from an open surgery is primum de nocere. Your collateral damage, the first principle of surgery of creating damage during doing surgery, goes down, and that's the primary principle of MIS. and it can be attained by following principles of any of these surgeries. MIS surgeries of multiple types. We are not going to talk about all the types of MIS surgeries. We are only going to discuss about this. We are only going to talk about posterior microscopic surgeries, tubular spine surgeries with a hint of microdiscectomy, MED, MIS, TLIF, and percutaneous pedicle screw fixation, with an overview about the OLIF that we'll be discussing in detail, maybe later webinars. Arvind, let me catch you on this. Now, what are the indications that you started with in your practice, and what all surgeries can you now happily and willingly perform with MIS tubular? Your voice, Arvind, your voice. You may want to unmute yourself. Yeah.
Yeah, like in everybody else, mostly, you know, we started with lumbar disc herniations, stenosis, stenosis in complex situations, then TLIFs, in complex situations like, you know, grade 2, grade 3 lytic degenerative scoliosis, then thoracic stenosis causing myelopathy, then simultaneously over a period of time, you know, cervical cases, cervical foraminotomies for cervical foraminal stenosis and cervical discs. And apart from that, you know, decreasing the size of the tube, diameter of the tube from 18 to 16, 16 to 14, 14 to 12, things like that.
Right, right. Bala, you have also gone and have been doing intradural procedures. How have your indications evolved? What were the first indications you started with? And today, what all things are you currently doing? What are your broader indications for MIS surgery? Remember, we are all talking about some 700 plus participants of this webinar. They would want to learn from where to start, what all indications to start with, and what is the scope and the wings they can attain over a period of time.
Yeah. So for those of you who are actually going to start doing tubes for the first time, I would suggest that, you know, start off with a very simple microdiscectomy. And especially what I would do is you could actually do a small open, like a microdiscectomy, and put a tube in through that and have a visualization of it and how it looks. And you can change between the tube. And that is probably how I would start. Then you go on to doing decompressions, you know, single level decompression, multiple level decompression, and then to TLIF. So I think do not start straight away doing a TLIF because you need to orientate yourself with anatomy, and remember that this is not normal anatomy that you're operating. You're going to have either a tight stenosis or you're going to have a large facet joint. So, you know, going straight away to do a TLIF or a tight stenosis would be difficult. So now, I mean, I started off doing almost, you know, 12, 13 years ago, purely, you know, tubular surgeries. And now I would do a lot of intradural, intramedullary. I've done a couple of lots of C1, C2, far lateral as well. So I've kind of really pushed a lot more, but it took me nearly, I would say, at least 5 years with just doing TLIFs, discs, decompressions before I started doing simple intradural, like a neurofibroma, which is a small, which you can just open the dura and it just pops out, to doing more of intramedullary tumors. I've done a couple of intramedullary tumors as well. But whatever you do, the important thing you have to remember is your end point of surgery should be exactly the same as you would do with an open. So there is no cutting short saying that, okay, you know, I can't see the tumor fully, but I'll just go and, you know, try and push, because neurological deficits will not forgive you. So, you know, you just cannot say that, oh, you know, it's a large meningioma, I can still do an intradural meningioma. Yes, you can if you're confident. So unless you're a neurosurgeon, I would not try to do too much intradural work. But, you know, if you are, you know, an orthopedic surgeon, definitely you can do multiple level decompressions, you can do far laterals, you can do so many things with this. If you're a neurosurgeon or if you're an orthopedic surgeon with experience of doing intradural work, you can push your boundaries.
I think this is something that is absolutely mandatory. One thing we all must remember, that please do not jump into this just because you have attended a webinar. We are trying to bring forth to you that MIS has advantages. There are principles of MIS. There are technical snags in MIS. You can all do MIS, that is 100% sure. However, you have to follow a certain learning curve. You have to start with the simplest case. And you heard Bala rightly that you can evolve from disc to LCS to listhesis to complex cases. Dr. Arvind even mentioned about evolving from a 22 millimeter diameter tube to a 20 millimeter to 18, and now he's been using 12 and 14 millimeter tubes, as good as like a endoscopic procedure in terms of the diameter of the tube, all through the same tubular technique. There is a learning curve involved. Dr. Vishal Pishattiva, can we catch you on this? We know that you have a humongous volume on the most complex spondylolisthesis. We would want to hear from you. When did you start doing these complex procedures? How many cases had you done before jumping onto this, and what were the concerns as you were evolving from simpler indications to complex indications?
I guess we started doing complex cases after about 7 to 8 years of doing grade 1 to grade 2 listhesis. I had an advantage in the form of my partner, then Dr. Devesh Dolakia. So there were always two surgeons on table. So we could push the envelope faster. So by 2012 was the first grade 3 listhesis we did. And from 11, sorry, not 12. And from there on, we've now found grade 3 and higher, we have crossed 50. It's not that you get to do these all the time, but yes, last 2 years, everything we do has been MIS. But initially, we would, the stiff ones, we would do open because the learning curve was there. But I guess it takes about 50 decompressions before you start doing fusions. By the time you're done about 15, 20 single levels, you're confident enough to go to the second and third level fusions. And about 150 to 200 cases is where you start getting into complex cases slowly.
Very pertinent. Yeah, thank you, Vishal. It was amazing to hear from you that you, Bala and Arvind both have mentioned almost the same thing, that it takes almost 5 years to evolve from a basic MIS surgeon to a complex MIS surgeon to a super advanced MIS surgeon. And that's the learning curve, the learning path, the learning ladder that everybody of us has to follow. We all have to choose the simplest case, probably convert your big open case into a mini open case, and then go to a microscopic and then convert it into a closed tubular procedure or a MIS procedure. Today, we are going to talk about problems which are related to the most common area of spine, which is lumbar spine. All these problems will be spoken to you about, discussed by these panelists, and the concerns also discussed. So Guru, can you tell us about your concerns while you shift from open to MIS surgeries? Like, what were the initial thoughts when you were shifting gears from being an open surgeon to a MIS surgeon? Were you not worried about incomplete decompression, suboptimal decompression, more technical problems? So what was running in your mind as concerns while shifting from open to MIS surgeon?
Basically, when you shift from a open surgery to a tubular surgery, main thing you're worried is your basically correct positioning of your tube. So I was always worried. Sometimes in initial days, your tube will be inadvertently get shifted laterally, or there will be a lot of muscle in between your lamina and your tube. So those were the main problems when I started initially. Then it was mainly to, as when you enter, to differentiate between the structures basically, because when the field of vision gets narrowed, it's sometimes if the ligamentum flavum is thin, you tend to start wondering whether it is ligamentum flavum or whether it is dura. You start wondering whether the chances of increase of damage to the dura increases with that. And then always you are worried about how much to cut the bone basically, because you don't want to create a pars lysis because your field of vision is restricted. That is one of the biggest worries you will have once you start in initial phase of phase. And then the next thing is always that when you do a over the top decompression, you might catch the opposite nerve root. So that's another worry you will always have. And then if there are adhesions, then whether you are, actually I was very careful in initial phase. If there is some adhesions are there, you can increase the chances of dural leak. So that's another thing. And then the central discs are the problem. The central hard discs, if that is there if you're, especially when you're doing a LCS case where is a big hard disc also in the center, always you are worried about incomplete decompression. And
Right. I
especially
think
whenever
all the concerns that all the concerns that Guru just mentioned, I think they are all valid. We all must understand that these concerns will surely rise in your mind, and it is absolutely normal to have a thought process that you are worried about the newer instruments like tubes, angled forwards, long instruments. You will always have a concern whether I'll be able to do good decompression or not, whether my instrumentation is going to help me or not, whether my patient will have adequate decompression done at the end of the
Vishal,
surgery or not.
Vishal,
Can I come in here?
Vishal,
Yes, Guru.
one
Quick
more
one.
point. Whenever we see that if we do a post-op MRI of an open case and a MIS case, you will always see that in open case, the decompression is much greater, but that is not required. So it's always that you will tend to do a little lesser as compared to open decompression, but then that amount of decompression is not required.
Vishal, one quick point, please.
Yes, please,
Okay,
Neeraj.
I mean, how I started, 12 years back, my first case was probably, this kind of a decompression. What I did was, I actually did an open exposure and put the tube inside the open incision. And that is how I actually graduated. So I'm very sure what I'm doing. That is how I got oriented myself. So that's one
Right. I think these are all small learning tips that we all must understand. What I'm trying to also bring out is that, like Guru and Vishal and Bala have mentioned, that it really takes 5 years to get completely acquainted with newer instruments and newer equipments, newer indications. You will really evolve out. The first thing that you all got to believe is conviction. You got to believe in yourself that MIS surgery is possible. You got to start believing in the fact that MIS surgery does adequate decompression, good fusion is possible. You can surely evolve as one of the best spine surgeons, like they are sitting here in the expert panel. And we also must understand that it is human to have these concerns, like Dr. Guru shared, and it is completely normal to have such concerns. Even with these concerns, please don't get worried and start venturing into the world of MIS surgery. Now, when we choose our patients well, let me catch Dr. Arvind. Dr. Arvind, what are the cases where you will not do a MIS surgery? We learned about indications where we need to start. We know where we can evolve. We know where all we can advance. But what are the two cases where you have regretted doing a MIS surgery and you had to convert it to an open surgery till date? I'm sure every surgeon has its own lobby of cases. That is one. And two, which are the cases which from here also you will not venture and do a MIS case? Strict contraindications.
Yeah, just to get some humor into this discussion, I've seen most of you, almost all the panelists are clean shaven. Have you been seeing patients?
We're coming on the webinar, so we wanted to look young in front of the senior guys like you.
Arvind, I had gone to hospital today, so I had to shave. Otherwise, if you saw my initial webinars, I was like you actually.
Okay.
Yeah, Arvind, even I had to shave because I was in my.
Arvind, you are not getting time to shave because you are still involved into video consultation and earning money out of it. You are sitting shaving 4 times a day, do nothing but shave at least.
They'll run away if they see me on a video like this.
I'm going to record this face of yours and put it on online so that all your patients get shifted to me now. Okay, your contraindications, Arvind. What are your contraindications?
Yeah. So, especially in cervical spine, there are many contraindications. I wouldn't still do it for myelopathy. I'm a bit scared to do for myelopathy. In a central disc in a cervical spine, obviously you can't do. You can probably go from the front, make a hole in the vertebral body and remove the disc using a Joe's technique. I'm not well versed in it. So, a central big disc in the cervical spine where you would do a regular anterior procedure. In lumbar cases, I think in lumbar spine, most of the situations can be managed with MIS. If it is a degenerative scoliosis, it is just the number of hours and the cost that comes in the way. Otherwise, each and every case in the lumbar can be dealt with MIS. It's very easy.
No, where you would not want to do. I mean, I'm sure with your experience, you can still do everything with tubular and MIS technique. But where you will not want to do it MIS way?
Want to do are those case situations we cannot do, like scolies, idiopathic scolies, cervical myelopathy, where there's cervical stenosis. These are two kinds of situations wherein I would, there's no technology to do them at the moment with MIS.
Right. Umesh, in your practice, When have you got to a situation where you had to convert a MIS into a open surgery and you regretted doing it?
Well, Vishal, to be frank, I know I have never had the situation where I had to convert MIS surgery, initially planned MIS surgery into an open surgery so far. But there are several cases where I would not choose an MIS surgery. So that is mainly because, as Dr. Arvind has already mentioned, as of now, the technology that we have is not feasible to do MIS in such cases. Most of them are instrumentation revision cases. And of course, grade 4 listhesis, up to grade 3, we have still done MIS. Grade 4, what Dr. Arvind told, he has done a spondylolisthesis recently. I wouldn't attempt that probably with an MIS surgery. But yes, as he's mentioned, most of the thoracolumbar cases, at least lower thoracic and lumbar cases, including sacral and iliac screw fixations, most of these can be done with an MIS technique these days. As we have attempted doing some cases of revision instrumentation doing with MIS, and we have been, we had to struggle a lot, but yes, we have been able to do it. But I don't think it is worth the time and the effort to do a revision instrumentation case as of now using an MIS technique.
Vishal, let me catch you on this. You have seen problems in MIS plenty like everybody else here. I'm sure you won't hide them, any of them, from us. Does severe osteoporosis or lack of anatomical landmarks worry you? For the sake of general population, I mean, we are 750 delegates here listening to you. What are the concerns when you plan your MIS that these are the cases you expect and anticipate that problems will come across?
Today, my main concern is in multi-level osteoporotics, because typically in a MIS fusion, the rod does not go to the screw comes to the rod. Whereas in an open surgery, the rod goes to the screw.
Very important point. I think that's something that we all need to understand, that we sometimes have to pull the screw to the rod through these tunnels.
So,
yes.
When you are doing, when the screw is going to come to the rod, the anchor better be strong. So the cutoff is -2. If the DEXA score is more than -2, I wouldn't do a more than 2-level fusion MIS. Then that's a straightaway indication for open surgery, for the simple reason that however ideally the screws are placed, while putting the rod in and trying to reduce it, I'm going to pull off 1 or 2 of those screws. It has happened in my hands. So first thing is osteoporosis is something where I would be very, very careful. 1 level, sometimes 2-level osteoporosis probably wouldn't make a difference. In fact, if it's a grossly osteoporotic patient, I prefer to do it MIS because the soft tissues are preserved and they add to the stability. The second issue is in cervical spine. Like Arvind said, it is still evolving in myelopathy. Lateral disc and all, and lateral mass screws usually is not an issue there. Where landmarks are not available, I use navigation with an O-arm. So usually, for even in those cases, for me, it's not a problem. But a good quality C-arm should take care. Like landmarks are necessary when you're putting in screws using landmarks. Well, in an MIS, you're using either a C-arm or a navigation to put in your screw. So in that case, not having landmarks, if your C-arm is not showing where you want to go, there is no business doing an MIS surgery. You must just open up. And
I think very, very pertinent point, like it is mentioned here. All MIS procedures are all C-arm dependent. They are all blind procedures guided only by C-arm. Whether it's guide wire, your screws, your tubes, everything goes into the body under C-arm guidance. And if you are not able to visualize anatomical bony landmarks well on your C-arm, you better not do a MIS surgery, otherwise you'll land up into a bigger problem. Ranjit, have you come across situations where you planned a MIS surgery, but because of one of these problems that are mentioned on the slide as contraindications coming from textbook, you had to convert it into an open surgery, either at the beginning of surgery or in the middle of surgery? Ranjit Unnikrishnan.
Yeah, yes, Vishal. Like all the faculty mentioned, most of these are contraindications. Like also as our expertise and our threshold level increases, we can try and move the edge. I have not had a time yet where I planned for MIS and I had to make it open. No, but there are cases where I will never even think of MIS. like what Dr. Vishal Peshetra mentioned, today osteoporosis, I was initially very hesitant. Today, with the current advent of all the Siemens, etc., I still try and do MIS in those. Re-revisions where I need to do re-instrumentations, I don't do MIS. I primarily go open. And today, more than 2-level TLIFs, MIS TLIFs, no, I don't do. I do OLIF plus posterior. Again, it's another method of MIS surgery because your struggle decreases. But I think that it's about like the level of the ladder, which is mentioned by all of you, is quite correct. The more we stay for a couple of years, and then we have to move the edge, see somebody do it. I still do more than 3-4 level cervical. I also attempt cervical myelopathy from the back via the tube. Again, the same methods what was mentioned here: open, put the tube. Again, from the tube, put the endoscope from endo. So that's how you climb up the ladder.
Vishal, Vishal.
Yes, Guru. Quick contraindication. We are on the contraindication.
It's basically what happens sometimes for the beginners before we had navigation and these robots and all. If you have a lot of aortic calcification, so sometimes you are not able to see your pedicles properly in the AP view when you're doing maybe instrumentation at the thoracolumbar junction or maybe in the lower lumbar region. So I had 2 cases where we had posted for a like percutaneous fixation, and then we couldn't see the pedicles properly, in the sense it was not possible to differentiate between the bone and the pedicle. So we had to convert them into open. So that is one situation we have faced actually. The calcification.
Thank you, Guru. I think
Vishal, can I?
Yes.
Vishal,
Bala,
can I mention
yes,
something?
quick comment.
Yeah.
Quick comment.
Yeah, very quickly. So, in one of the situations where I was actually called to operate in a pediatric neurosurgery, live surgery demonstration, was to do an MIS tethered cord release. So, MIS tethered cord release. So this child was had deformity, but obviously had a tethered cord. But the distance between the skin and the lamina was so short that even the shortest tube was sticking out of the skin right up there. So, once we went in, I saw that I knew it was going to be not easy, but then I attempted to put it. But then basically all I needed is through the same hole, I just need to use an McCulloch's or, Ramani retractor, and I was able to do. So a very, very thin patient as well, docking the tube is extremely difficult. That's when I realized in that case, and then I have observed that over a few cases, because your tube is going to be sticking out of the skin, and so it's very difficult for you to kind of work around that. You know what I mean?
Right.
I don't know if anybody else has had such experience.
Right. I think it's a very pertinent thing. We have plenty of such thing to come across. We started with the basic advantages of MIS surgery, types of MIS surgery we discussed. We spoke about the indications and how they have been growing. We spoke about the evolution of MIS surgery. We spoke about the evolution of MIS surgeons through the learning curve that you can actually address from the simplest cases to the most complex cases. However, for the sake of benefit of everyone, we all must also respect the word of all our panelists that they've come across, that there are some cases which they may not want to do even today with MIS surgery, which actually are strict contraindications for doing MIS surgery in the benefit of patient. And there are some relative contraindications, at least for beginners, where you will not want to do MIS surgery. Some of them have been listed here in this slide. Also, whenever you're doing a MIS surgery, for medical-legal reasons, it is absolutely pertinent to have spoken to your patient. Guru just mentioned one of the case scenarios which can come to you for various reasons. I'm sure Umesh, Bala, Arvind, and other guys also would agree with this, that whenever you are taking a consent for this patient for MIS surgery, please mention that for inadvertent, unknown, unanticipated problems, sometimes the MIS will have to be converted into an open surgery. And if this line is not mentioned in your consent, you may be in a bigger problem if you're not able to, or you will be forced to do a suboptimal job. So Bala, do you have any such similar lines in your consent form as well for MIS surgeries?
Don't have, but as you said, it's a very important, maybe I need to, so, I don't have a separate column or a form in the form, but I always write maybe converted to open. As most people agreed,
Yes,
I've not had any, so far I've never actually what I've planned to do as an MIS, I've never opened up. But you never know, it may happen to me someday.
Right. I think very pertinent point, and I'm sure we all from here will take it a word that while following the principles of MIS surgery, while fulfilling the indications and the surgical the outcome for the surgery, we would follow these principles and keep ourselves and our interests also safe, apart from giving the best of spine surgery to all of them. Now, before we go on to the surgical technique of all these procedures mentioned in the slide, I would like to come back to Arvind. Arvind, you mentioned that you bought a tube when you started doing your MIS surgeries. What are the other requirements that every young guy should keep in his armamentarium? So basic requirements, apart from having a conviction, the rightly indicated patient, all contraindications have been ruled out. What is the armamentarium that his OT should get equipped with before he plans to do MIS surgery? Can you tell us about your OT setup and how should a young guy go about it?
Yeah, so first of all, you can't do a tubular surgery without having without having any knowledge about the microscope. You should have some experience with the microscope, how to zoom it, how you should actually use the microscope prior to, you can't be a hero and start everything on day one. So you should be good with the microscope. You should be able to do a microdisectomy at least.
I think the most pertinent requirement of doing microscopic or MIS surgeries is getting used to a microscope. And you may not be a master of microscope on day one with a tubular surgery. And it's very important to cross the learning curve of microscope, doing ample number of open microscopic surgeries where you have a bigger exposure and you're doing surgery in the microscope. And the simplest one of them being a microdiscectomy. Arvind, what next? What other things?
Yeah, you should have a good quality CM, image intensifier. These are all blind procedures. You're not opening up. So you have senior surgeons. So you have senior surgeons, even if they want to do a L4-5 discectomy, they expose all the way till the sacrum and see whether, they catch hold of the spinous process of L5 and S1 and to check which is mobile and which is immobile. So this is not the story here. Here, everything is image guided. So you should have a good quality.
Thank you, Arvind, for bringing out the two most basic requirements: good CM, a good microscope, and having understood the principles of playing on a microscope, having understood the principles of playing on a CM to get a true AP image, true lateral image is absolutely mandatory. Remember what Arvind said, MIS procedures are all CM driven. They are purely blind procedures. Unless you have a good CM, you may be landing up into a wronger place. You may be doing a wrong level, even with a MIS surgery. So you have to be absolutely sure that you are very well used to and very well past the learning curve of microscope and a CM. Bala, what specific instruments do you ask for? Arvind has mentioned about microscope, a good tube and a wide armamentarium of tubes, and also a good CM. Other than that, what are the instruments that all young guys should have while starting MIS surgery, tubular MIS surgery?
To actually plan your instruments, you have to make sure that you have long instruments. So starting from your bipolar, monopolar, your forceps, your upcutters, they all cannot be the standard. They have to be long. They have to be either 160 to 200 or more, depending on the depth of your patient. And now I've recently actually acquired a new set. We actually got it from Medtronic, imported from the US, where we had much more longer instruments because we're seeing even more obese patients, where even the regular long ones are not sufficient. So long instruments is the key, even the bipolars, even the monopolars.
Very important. I think all the delegates have taken this very clearly, should remember and write it down. You need a separate set of longer instruments. Remember, in your open surgery, your hand is working nearer to the bone. Here you have a skin, muscle, fat layer, and in an obese patient, you are really far away from the target area and you are working on the skin level, and that is why your instrument length has to be literally longer. Anything else, Ranjit? Other than longer instruments, bayonet instruments, curved instruments, good microscope, what other instruments do you keep in your OT ready, absolutely ready when you're doing MIS tube surgery?
Vishal, like when you asked the question earlier, have you converted something from MIS to open? So there, in the early part of my career, early part of my learning phase, the particular day the CM does not see well, I'm not able to see the landmarks well, I have converted to open. No, I planned MIS. Same way here, if I don't have a good CM, rest all have you mentioned very well, and it's my plan B. In case I cannot do this MIS, I'll go open. So I also should have everything ready for my plan B open also. Nothing, let's all have you mentioned out here.
Right. I think perfect. So what are the other instruments that you keep with you? Instruments. What instruments your armamentarium in your OT mandatorily have to have for to do a MIS? We have spoken about long instruments. We have spoken about microscope, CM. Anything specific that without which you will not start your MIS surgery?
Okay,
Well,
Vishal, if I can say, sorry.
Yeah, go ahead, Bala.
No,
Yes,
along
please,
with
Bala,
the
please.
regular instruments, also micro instruments. You have to make sure that you have long micro instruments, because you never know when you are going to get a dural tear. So especially your needle holder, needles, they also have to be long, because you prepare everything else, but if you don't have your micro instruments, then again you'll be stuck. Sorry, go ahead, Neeraj.
Yeah. Meanwhile, I'll request all the panelists who are on panel to please keep checking the chat messages. There are a couple of questions coming up which we may not be able to take up. So on the chat section, the panelists are requested to please answer the questions that are coming from the delegates. We will keep it more interactive for them. So all panelists, please keep checking the chat section and keep answering them. Yes. So Neeraj, what is that one instrument without which you will not start your surgery?
I mean, most of the instrument panelists has already included. One thing which probably I do keep, maybe I mean, other than most of you is one is suction root retractor. Probably I'll not operate any of my MIS without that matrix, the Medtronic suction root retractor, because I mean, most of the time you are doing over the top decompression, you tilt a microscope, you tilt a table, your assistant might not be of much help to you. So I mean, you will have to use your left hand to and do with the right.
Wonderful. I'm sure all the delegates are getting advantage of this. Ayush, quick one.
So
One instrument without which you will not start.
High speed burr is a must when I'm doing
high speed burr. Yes. I think this is what I wanted to hear for the sake of everyone. You must have a high speed burr. Of course, you can do without it. However, sometimes something that high speed burr can do, no matter how good forwards you have. So please try to have a high speed burr in your OT. Arvind, let me catch back to you again. One instrument without which you will not start your surgery.
No, forget starting. You will get, you will get googled in the first minute of surgery. That is, you need to have a long cautery tip.
Long cautery tip. I was actually wanting to listen a long cautery tip and a nerve hook. If you do not have a long cautery tip, you will not be able to get this. Why, Arvind? Why do you need a long cautery tip?
Whenever there is a demo surgery anywhere, first thing I mean, irrespective of whether that particular host institute has it or not, I put one in my pocket and go, because I've got unawares once and it was quite tragic. So the only way you can burn the soft tissues is with the cautery, and here you need a long cautery tip. Your short cautery tip won't go, and bipolar is not sufficient.
Yes. I think that is a comprehensive list. I'm sure every surgeon has his own preferred list of instruments. However, something as a basic that we all must understand, that your OT should be very well equipped apart from all of the basic things. You should have a good microscope on which you can work. You have been trained on that microscope. You have passed the learning curve. You should have a good CM, which is not only showing you a broader field of 3 or 4 vertebrae in one go, but also has a good penetration power and good amplification of the bony tissues, which can show you even in severe osteoporosis, bony landmarks are not obliterated. Very, very important to have true AP, true lateral. We also heard from Vishal Peshattiwa that it's a teamwork. If your technician is not good, if you have not spoken to your technician, you are going to be having a big challenge, because sometimes they will not understand what you require from the imaging. And that is why talking to a technician, talking to a nurse is something that is very important. Keeping a long cautery tip, bayoneted instruments, bayoneted forwards, long dispunches, a long nerve hook, a bayoneted nerve hook are something that I normally use. A good bent 90 degree to 60 degrees bent suction tip along with a nerve root retractor attached to it, like Neeraj mentioned, comes very, very handy. A high speed drill burr sometimes is a lifesaver for all of us. And that is all these things you have to keep in your armamentarium before you go ahead with this. Let's go on to with all these armamentarium in a rightly selected patient. We are going to perform all these surgeries today. We are going to see how all these surgeries are done. And let's go on to our first procedure, microdisectomy. Now, we all know that we do perform decompressions. Arvind, while you are doing your decompression, what is there in your mind? I mean, what is your end point before you start? what all you want to achieve at the end point, and when do you call it a day? कि नहीं बस अब मेरा decompression हो गया and I am done with it. I would not want to do anything more. Can you elaborate?
Following a discectomy? For a discectomy, you mean?
Yes, anything. I mean, let's talk about a decompression for this particular case scenario where your axial image shows lumbar canal stenosis. So what all things are there in your mind when you are planning, and what is your end point that you will stop there?
So here you see it is a very severe stenosis, and if you appreciate it, it's mostly a soft tissue stenosis. There's no much bony stenosis here. So if I can easily remove all the phlegm around, I'll be happy. The roots will be free. So there is ipsilateral as well as contralateral lateral recess stenosis, and there is central stenosis. The thing is, if you decompress the ipsi as well as the contralateral stenosis, lateral recess stenosis, automatically the central stenosis will be taken care of. So what I would be, my end point would be, that both the roots are seen all the way till and beyond the pedicle. I should be able to feel the medial wall of the pedicle on both sides. So that is my end point, and the root should be mobile, and this.
Yeah. So I think Arvind has already highlighted removal of soft tissue and bony compression, bony removal of laminotomy, removal of the phlegm which is hypertrophied, lateral recess decompression so that the lateral aspect of the nerve root can be seen. The nerve root should be free enough. If there is a disc fragment, should have come out, and a broad foraminotomy right from the shoulder all the way to the foramen. I think this is the basic principle of decompression. May you do it open surgery, you have to achieve this target. May you do a MIS surgery, you have to achieve this target. The target surgery doesn't change at all in a MIS surgery. You have to achieve that target surgery, and the endpoint has to be decided well in advance. And this doesn't change at all, no matter what kind of MIS surgery you are doing. And to achieve this target surgery, there are various ways to do it. There are conventional ways of doing it by doing a wide open laminectomy or interlaminar decompression. However, there are downsides. We already spoke about the advantages of MIS surgery. And then there is this whole new era of minimal access surgery, which genuinely primarily indulges into saving the posterior musculature, saving the posterior interspinous ligaments, saving the posterior midline structures to be precise, and it can be done by various ways. We are going to have Dr. Neeraj soon to share his slides upon microdiscectomy. Neeraj, are you ready?
Yeah, I'm ready.
So I think we are going to listen to you about microdiscectomy for a patient with PIVD. Can you please elaborate? And I'll ask Sai to allow you to share your slides from there. Dr. Sai, can you allow?
Yes, sir. Yes, sir.
So Vishal, I have only kept technical aspect. I'm not going much into theory here because I guess theory is at such point.
Yes, we just want 3 or 4 slides from you about how to do a microdiscectomy.
I'll just quickly go through, this is basically a snapshot of a technical video which I have already uploaded on YouTube. I'll be sharing a link to group. People can later on see. I'll just quickly.
Yes, and I'll be sharing some articles on microdiscectomy as well.
Correct. So I'm not sure whether my screen is being shared or not.
No, you will have to start sharing your screen.
Okay, I'll have to do that. Wait, now let me check.
Yeah.
Okay, yeah.
So Vishal, while he's setting up, Vishal Peshetiwar, what is the difference between a tubular discectomy versus a microdiscectomy?
In fact, I was just answering the question on the chat. Now, when you're doing a microdiscectomy, you're going in the center, you're detaching the paraspinal muscles of the spinous process and the lamina, and then doing your job. Whereas when you're doing an MIS discectomy, you're just putting in a dilator. You're dilating the muscle, drilling the lamina, and taking the disc out. Now, probably at one level, a microdiscectomy and an MIS discectomy, the mobility is the same, but it starts making a difference once you start doing the fusions and once you start doing multi-levels. So unless you have done enough MIS discectomies, you'll not be able to do a good decompression. You'll not be able to do a good fusion. So even if the mobility is very little, when it comes to a microdiscectomy vis-a-vis a MIS discectomy, there's a huge gap when it comes to a midline fusion compared to an MIS fusion. An MIS fusion, the morbidity is going to be very little as compared to. So you start a lot of like there was this argument made by one of my colleagues saying it is the same thing, the incision is the same. It's not the same thing. It is not the same thing. It is a completely different principle. If somebody says that a microdiscectomy done via Michellock's retractor and an MIS discectomy done via a tubular retractor is the same, they have failed to understand the basic principle of an MIS discectomy, and they should not take up micro. This has happened to a lot of our senior surgeons who say, "Arey, ye to same hai, arey, ye to same." It is not the same. It is very easy for the orthopedic surgeons to get and say it's very easy to cut the patellar tendon or knock off the tibial attachment of the patellar tendon and do a TKR. You'll get a beautiful exposure. You'll do a nice job, but it's a useless knee because the patellar, the whole quadriceps mechanism has gone down by 1 grade because you have cut the patellar tendon. Similarly,
I think message is very clear. There is a huge Yes, Vishal, wonderfully elaborated, beautifully told about the principle of MIS surgery. I think 2 points that Vishal mentioned here very clearly is one, that microdiscectomy is completely different from a microendoscopic discectomy. One involves stripping of muscles from midline, one involves going between the muscle by dilating the muscles. And second point that he highlighted is that we all have to learn microdiscectomy, because unless until the basic procedures are understood, advancing ahead can give us a trouble. And to reduce the learning curve of microendoscopic discectomy, it's not a bad idea to do microdiscectomies. We are going to listen to Neeraj, and he's already shared a link where the whole video of microdiscectomy is kept. We are soon going and coming up with microendoscopic discectomy and see how MED is done. Yes, please go ahead. Arvind, meanwhile, if you have a video on MED or some slides on MED, can you pull out your slides on that, please? Neeraj, back to you.
Okay, so I think this is a patient which we have operated on L2-3 disc. If you can see on the screen, I'll immediately will go to the technical aspect. This is the midline incision what we use. You can see I've drawn a spinous process, lamina, and interlaminar space also here. This is the spinous process. So my incision starts from the top edge of the spinous process to the bottom edge of the spinous process. And this is a disc space which I have marked. I have confirmed the level. You can see the needle which is there. The needle will be there till the time I confirm under my C-arm. This is once you have put skin and subcu incision, this is the fascia which is getting released just lateral to the spinous process. Once fascia is released, directly you have to go to the bone for a subperiosteal dissection. You can see this is a bone which is there, and my cautery bovie is directly erasing the muscle subperiosteally, so there is very little bleeding, and the muscle damage is also much less. You can see this, the entire lamina has been exposed. Here you will see the facet joint, and you can see this, the complete exposure. Now, there are 2 types of retractor what we used. One, as Vishal said, there are Michellock's retractor, and what I use is a weight retractor. You can see this is a weight retractor which is hooked on this facet joint here. It looks like something like this. This hook will go on the facet, and I'll hold it with this weight. But traditionally, you can use this Michellock retractor also for your microdiscectomy, wherein the hook goes into intertransverse space, and this blade retracts the paraspinal muscle. Once you have done that, you can see this the facet joint, a hook, and a clear ligamentum flavum there. You check your level by putting a penfield there. Don't go inside without confirming your level twice, thrice, as many times as you want. Use your burr to do a small laminotomy. You can see the ligamentum flavum which is here. Once you have removed adequate bone, you can see the ligamentum flavum, and you can see a small opening medially where the ligamentum flavum ends at underneath the lamina. Hook your ligament with a nerve hook from the dura, and you can remove the ligamentum flavum gradually to expose your dura. Now this is the upper lumbar level, so you really need to remove entire ligamentum flavum. But if you are at a lower lumbar level like 4-5 pias 1, where you have a wide interlaminar space, you can just nick laterally to the ligamentum flavum, directly go lateral to the root and do a microdiscectomy. You don't need to remove entire ligamentum flavum there. So once you have removed adequate, gone lateral to the root, you can use your nerve hook to see the ruptured disc which is seen here, and do a tease out of your disc, and disc is out. So these are the basic simple steps of microdiscectomy. You can see my narrated entire video on a YouTube link which I have shared, and you can see it at leisure, because it's a 12-minute video, so I don't have time to discuss that over here, because there are a lot of technique we need to discuss. Vishal, over to you. Arvind, you can take over. Vishal is not there.
Yeah. So
I'm here. So anyone has any questions on this now so far?
Well, I guess, this is everybody does that. So I don't think there would be any questions over here.
I think this is the basic. This is the basic of any MIS surgery, microdiscectomy, and as we just learned across. Yes. So Sai, I would like to share my slides from here on. Neeraj, you may want to stop the sharing. Yeah.
I've done that.
There's a question there. Somebody's asked whether you have to only remove the fragment. Neeraj, what would you do?
Sorry, come again.
No, there was a question that's just popped up, which somebody had asked about. If there was only a sequestrated fragment, would you only remove the fragment, or would you still go into a formal discectomy?
Actually, if you go to the video, this is only the sequestrated fragment which has been removed. Here also, we have not removed, not gone inside the disc space.
I think that's a very pertinent question. How much disc to remove? In our previous webinar on disc disorders, we have spoken about it. But let's take this question here. Vishal Peshativa, how much disc do you remove when you're doing a discectomy, irrespective of what technique you're following? If your access
whatever is lying outside, I take it out. If there's an anatomy seam, I will go through that, take out with gently whatever comes easily, and then cauterize that anatomy, and that's it. I do not do too much of work inside the disc. Whatever is sequestrated or herniated, take it out. Rest of it, leave it behind.
Ranjit, there has been a world of spine surgeons who believe that subtotal discectomy, you got to go inside the disc and remove all the loose fragments from inside there also. What is your take on that? Subtotal discectomy versus only fragmentectomy. How much to remove and what not?
The fragment has to definitely come out, number one. Number two, go and remove whatever is loose inside the disc space. Don't have to go and clean out the entire disc space like you do for a fusion.
Right. We have Sandeep Sonone with us. Sandeep, are you there? Sandeep Sonone? I think we have just missed him. Umesh, are you there with us?
Yeah, Vishal.
Umesh, what is the difference between recurrence rates in patients where you have removed only fragmentectomy versus subtotal discectomy? On one hand, you are only removing the fragment lying outside the annulus, versus in other hand where you are going inside by doing a small annulotomy and going inside the disc. Do you feel in your practice you have been doing one or the other or both, and you have a difference in recurrence rates among the two?
Well, yes. Not all cases will suffice by doing a fragmentectomy alone. If the disc is healthy and if the annular defect is small, like usually less than, the literature says it's less than 6 millimeters, but if it is less than 1 centimeter, then you can just do a fragmentectomy without widening the annular defect, and then probably through that same annular defect remove the loose fragments that are still within the annulus, because that is those loose fragments within the annulus, these are the ones that are more responsible for the recurrence, and also these prevent annular healing, which we expect to happen over a period of time. So whatever loose fragments are there, that we have to remove along with the fragment. But obviously there are some cases where we have a diffuse disc bulge, where the annulus is quite incompetent and where a large annulotomy will be required. So whenever, at least in my practice, whenever I do a large annulotomy, you may have to do a subtotal discectomy. Means it's not like an aggressive discectomy as was recommended earlier days, but at least you remove a larger amount of the disc material than what you would have removed by fragmentectomy alone. As long as the annular is less than 6 millimeters according to the literature, and you remove only the fragment and the loose fragments within the annulus, the recurrence rates are similar to those cases where you do even a subtotal discectomy with the same annular defect. But if the annular defect is bigger and you don't remove enough of the disc material, your chances of recurrence are higher. And this has been shown by a the Carnegie study. So where the recurrence rates are as high as 20 to 25% when the annular defect is large and aggressive or a subtotal discectomy has not been done.
Bala, since you started this discussion, I think Bala has gone somewhere. Ayush, in a large central disc herniation. It's one of the challenging jobs in even lumbar spine, where you have bilateral symptoms because of a large central disc. You will be forced to not only handle the neural structures, but also do a big annulotomy. It's like something very important to do to get the fragment out. In those situations, what do you do?
So large central disc, if it's a tall disc, the patient is tall, I won't do a distant simple discectomy. I prefer a fusion in these cases. I have burned my finger. I did a tubular discectomy and I got a recurrent disc prolapse the very next day in a 6 feet tall patient with a huge disc height, and it was a straight away cauda within 24 hours. So from that day onwards, if I have a large central disc with a very good disc height in a tall patient, I won't do a simple discectomy or fragmentomy. Maybe it's a personal choice or personal opinion. What happened to one of my case? I prefer a fusion. I don't.
Yeah, I think it's a different view of looking at it. Arvind, we have heard you talking about doing no discectomy also in patients with radiculopathy. What are those special case scenarios?
So these are patients where, primarily the symptom is not of a disc herniation. The symptom is more of a stenosis. So these patients clinically, when you see them, when you're not seeing their MRI, they appear to be claudicant patients who have neurogenic claudication. So they, unlike disc patients with disc herniation who have pain on flexion, that is on sitting or bending forwards, these patients get relief on sitting or bending forwards. And they get pain in extension. Extension could be lying down in extension. So they like to lie on the sides, or they basically have neurogenic claudication. They walk or stand for some time and they get pain. So there is a lateral recess problem. It is not a problem of the disc. The disc, initially it is a chemical reaction that causes this irritation the first few weeks. So then if that persists, that is when you do a discectomy. Over a period of time, the same discs, either they shrink in size or there is calcification around that area. And over a period of time, secondary degeneration sets in. So combination of a hard disc in the front, a hard annulus in the front, plus a thickened flavum at the back, that causes lateral recess stenosis. So these are patients whom you can pick among the patients that come to you with leg pain. On X-ray or on MRI, they have a disc bulge, big disc bulge. They have lateral recess stenosis. And all that you need to do is you just need to, de-roof the lateral recess. So these are elderly patients.
I think message very well taken. So this is a debate that I think still the world of consensus is yet to be established. We all know that doing a discectomy, the primary aim is to decompress the nerve root right from shoulder all the way to foramen. What is the amount of disc you remove? More often than not, doing only sequestrectomy or fragmentectomy, which means lose sequestrum plus lose fragments from inside the disc without increasing the size of annulus, is something very important. In large discs, central discs, calcified discs, the world of debate is still open and controversial, and their personal choice and experience really makes a big difference. However, it is said that recurrence rates are higher if the annular defect is bigger, or if you have to enhance the annulus defect by your knife by cutting it across, the chances of having recurrence is very high. And that's same to whether you do a microdiscectomy or you do a MED. So Vishal, let me come back to you. You just mentioned about the downsides of microdiscectomy, and there are advantages of tubular. Can you please highlight to us? We know that in microdiscectomy, Maculox tubular retractor is used where multifidus damage due to forceful retraction with the help of blade of Maculox happens, and muscle ischemia and denervation happen. Can you elaborate about how tubular takes one step ahead into the world of tubular MIS surgery?
So you want me to talk about the advantage of the tubular?
Yes. How is it different? How is it different, and what is the difference that it brings in terms of technique?
Technically, the biggest difference is the dynamic. There are two stabilizers in any musculoskeletal system: the static ones, that are the bones, the ligaments, and in spinal, in the vertebral column, the disc, and the dynamic stabilizers are the muscles. Both of these come together to hold a very stable spine. The moment you're going to do a midline dissection and remove it, the paraspinal muscle is going to get denervated over that area. The entire vertebral column is like a suspension bridge. You snap one cable, the whole bridge becomes unstable. In fact, some of the European people now talk about the Mongol bow stability in the sagittal plane. It's beyond the scope of this, but what I wanted to say is the moment the midline is disrupted, you are creating iatrogenic instability. The advantage of a minimal axis paraspinal intramuscular approach is you don't cut the muscle, you dilate it. Of course, there is nothing like a zero trauma approach. There is going to be some amount of muscle which is attached to the lamina or over the facet that you will have to remove. But this is a much smaller damage as compared to an open, even if it is a microdiscectomy, there is a much smaller damage. Second thing is this is a targeted surgery. You want to take out a sequestrated disc, migrate it down, you dock your tube exactly over it, take the part out and get out. You don't need to damage what is not faulty.
Right. I think Vishal has brought the principle. Yes. I think Vishal, thank you, Vishal, for bringing out the principle of microendoscopic tubular decompression. It is just another way of doing the same target surgery like you do it in an open surgery or a microdiscectomy. It involves doing the same decompression. Mind you, the target surgery, the principles of decompression don't change, just that you do it with a tubular retractor, which is like a cylindrical tube, which is docked on the bone where you have to do laminotomy. It is done under microscopic guidance. The incision size is less than 2 centimeters and often can be done as a day care procedure. The principles of this involve the same. You do the same flavectomy, you do the same recess decompression, you do the same discectomy, foraminotomy, and all this is basically done with the help of a tube, and that's what changes the whole world. And if you see, the incision, like Vishal mentioned, is not median but paramedian. And that is why the tube dilates the muscles and travels through the fibers of the muscle without disturbing them, and it spares the multifidus. So what we have been talking about since afternoon is sparing the posterior musculature, minimizing the collateral damage, and this is something that makes it a different procedure than a conventional microdiscectomy, which is still a gold standard for discectomy procedures. However, the advantages of tubular are that it spares multifidus, it dilates through a paramedian incision. You can do serial dilation with the help of your tubes. Arvind is soon going to show his video on how do we do a MED. The best part is it doesn't damages the muscle. There is no denervation that happens. And the principles of tube docking, like we heard Dr. Guru Raj and Dr. Vishal Peshattiwar to speak about, that the one thing that we all must master is tube docking. So if you want to avoid 90% of your problems and your concerns regarding adequate decompression will happen or not, whether I'll be able to do a good fusion or not, whether I'll be able to do a opposite side good decompression or not, the one principle that I think all of us do completely believe is upon tube docking. Where do we dock the tube? How do we start? Where is the position of incision? What is the angulation of the tube in terms of mediolateral, in terms of superior, inferior? In what line does the tube lie? This is something that let's hear from Arvind. Arvind, in these 3 case scenarios where the symptoms are on the left side, only on the right side, pardon me for writing left there, the symptoms are on the right side in all these 3 patients. Which side will your tube come, and what are the points that you consider while doing a tube docking? And then let me catch up on each panelist of their preference and their points to consider while tube docking. Arvind. Bala?
As you highlighted, hello?
Yes, Arvind. Yes, Arvind.
Yeah, as you highlighted, tube docking is, proper tube docking is half the work done, according to me. So, and in these cases, it is very, very important. So in L5S1, the lamina is very big. The facet is also very big and it is coronally disposed. Usually it is not an issue with L5S1. Here, I would go on the right side itself because there is a disc on the right side. So it would be suicidal if it would go from the left side. In the extreme right L5S1 disc herniation.
Okay.
And in the second one, so if there is a facet cyst here, so if this facet cyst was crossing over to the opposite side, it is very difficult to create a plane from the ipsilateral side. So in that particular situation, I would probably go from the opposite side, from the left side. But here, I think once I do a laminotomy, I'll be able to create a plane between the dural sac and the cyst.
Right. And in the third case?
Third right. So for a right-handed surgeon, it is easy to do a LCS decompression from the right side.
Right.
This is because, you know, the inferior part of the flavum where it gets attached to the superior lamina of the inferior level. So that is very difficult for inexperienced hands to excise that part of the thick flavum, and you might cause injuries, dural injuries. So for a right-handed surgeon to excise the inferior part of the flavum, which is attached to the superior lamina of the inferior vertebra, it is easier to go from the right side.
Right, right. So if you see, Arvind was trying to look at different types of pathology and the location of pathology. That was very important in his consideration for which side will he dock the tube. Umesh, what are your points while tube docking? What are the other anatomical, pathological, radiological factors that you consider?
Well, for
the sake of delegate, what all things should we keep in mind?
So we should consider, of course, what is the pathology and what is the nature of the pathology that we are dealing with. And we should consider clinical symptoms. Which side is the patient having most clinical symptoms? But naturally, in many cases, and of course, the third most important thing that we should consider is the plane of the pathology, like whether the pathology is intra-canalicular, whether it is in the lateral recess, or whether it is in the foramen, or whether it is in the extraforamen. Based on that, we can actually access where we should approach that particular lesion from. And so in this particular case, even if the patient, especially in the third case, even if the patient symptomatology is more on the right side, so it makes worthwhile attempting that lesion more from the left side and going contralaterally, because you may have to remove the subarticular portion of the ligamentum flavum and also the overhanging portion of the superior articular process, which is probably better done, and into the foramen also, which is probably better done from a contralateral side than from the ipsilateral side. From the ipsilateral side, if we try to decompress this foramen or the lateral recess aggressively, we may cause some kind of a facetal.
Are you? Yes. I think message is very clear. Yeah.
Because already you can see some amount of facetal slip over there. So probably
right.
I would probably think that this particular axial section is a case of partial, probably a degenerate scoliosis with an asymmetrical canal stenosis and asymmetrical facetal hypertrophy. So these lesions, if doing a single level decompression, it's always better to approach from the contralateral side, because here we can effectively decompress the lateral recess as well as the foramen without compromising the facetal integrity. So also,
Bala, does the yes, Umesh, Bala, does the facet tropism worry you sometimes? Like if a patient with right side has a very sagittally oriented facet, would you be worried that if your tube gets docked there, you will damage the facet on that side? So facet orientation or spinous process angulation, sometimes does it worry you?
Yeah, it does, because what will happen is you will be ending up removing more of that facet and you will make it more unstable. So as Umesh was explaining correctly, you probably would be able to see the contralateral side of your root, and even you can do a discectomy actually on the contralateral side. Over the top, you can still do even a discectomy. That I wouldn't do unless you're very experienced with the tube and how you can adjust it. So yes, the alignment of facet, how big the facet is, what side is the pathology, and if the symptoms are bilateral, you should be ready to explore both sides. So I think I agree with all their points.
Right. I think the message is very clear, like what Arvind started. Vishal, what is that one landmark that you always rely upon while giving your your docking of the tube or your guide wire goes in? What is that one landmark on the bone in terms of MED, in terms of TLIF, and in terms of far lateral disc? Is it different, or you get your tube first docked always at that one point?
No, it's always different for different surgeries. If I have to do a decompression, I would start with a medium-built person at the line joining the medial aspect of the superior and inferior facet. If it is the fusion, I would start at the line joining the outer side of those, not the facet, sorry, I beg your pardon, I would draw a line between the two pedicles, the superior and inferior. The medial aspect of the pedicles would be the entry point for a decompression or a discectomy. And for a fusion, it would be the lateral, the line joining the lateral aspects of the pedicle. If it's a fat patient, I would still go more laterally, maybe 1 or 2 centimeters laterally, so that it docks right over the facet, that because I'm doing a transforaminal fusion. And to do that, you have to dock exactly over the, the superior facet, the cambium triangle. And for that, you need to go on the outer aspect of the pedicles. The line joining.
I think very well elaborated. Thank you, all the panelists. Arvind started by saying where exactly is the pathology lying, whether it's a disc, whether it's an inferior migrated, whether it's a superior migrated, whether the cyst or the disc is crossing the midline, whether the facet joints have a tropism, are the facet joints nearing the spinous process, is the spinous process in midline, or there is an angulation of the spinous process, making our tube docking going to be very difficult. All these points have to be taken into consideration. We must understand that the surgery involves removal of these yellow ligaments in all cases to decompress either ipsilateral, contralateral, or both sides, to decompress the traversing nerve roots, and sometimes to decompress exiting nerve root on one side or the other. If you are doing a fusion, you would want to remove this whole pars. If you are doing only decompression, staying away from the pars and the facet joint being more medial is very important. And that is why it is very, very important to get your tube docked at the right place. If you are too superior, you will never be able to reach the disc. If you are too inferior, you may only get an inferior fragment, but difficult to enter into the annulus. If you are too lateral, you will probably sacrifice the pars and will not be able to do a contralateral decompression. And if you are too medial, it will be extremely difficult for you to do a lateral recess stenosis decompression ipsilaterally. And that is why getting the tube docked at the right place is the most important thing. And there are variables that decide on which side, which site, what place do you get your tube docked in. And this is what all about planning is. And believe me, the planning of your tube docking cannot be overemphasized. That is 75% of your surgery done. When you really enter in, everything should be clear in your mind that where exactly are you going to get your tube docked in. A simple parameter or the landmark is that your tube should be docked on the spino-laminar junction, which should be able to see a part of lamina, a part of ligamentum flavum, a part of pars, and all these three things should be seen. And we have been discussing this, that MIS is a blind procedure. It is purely guided by CM images, and that is why all the anatomy, where exactly the pathology is lying, should be extrapolated on the CM images, and you should be able to make out where the spino-laminar, this red color line is the spino-laminar line. This is the spino-laminar junction, what a lamina looks like, and where is the open yellow ligament area, interlaminar space. Because if you do not anticipate that this open area is there, your guide wire may easily get slipped in and you may damage the durally. And this is one thing that we all must follow the advice of all the panelists, that please pay attention to all these parameters. You should be able to localize this AP lateral images in a true manner. You should be able to get a pars image, a spino-laminar line image, spino-laminar junction should be highlighted. Interlaminar space, how clearly it is seen here, should be able to see. You should be able to get your guide wire, the blunt side of guide wire, docked on the spino-laminar line junction, and that's when your tubular dilators come in. And this is the point where you may want to get your guide wire before you dock it. And these principles, Dr. Vishal Peshattiwar like highlighted, that for a decompression, your tube looks like that, whereas it goes laterally when you're doing a TLIF, and it goes further laterally when you're doing a far lateral. Your up-migrated disc will have a tube looking at it, whereas for a disc, where you're doing a disc herniation, which is not migrate up and down, it should be absolutely in the line of the disc. And L5, S1, it should again be in the line of the disc. Always on a lateral image, your tube should be looking towards the disc. You cannot be missing upon that. So we are going to see all this in a video very soon. I had a video, but I think Arvind will be able to show it from there. I'll stop sharing from here. Arvind, are you ready with your video there? Arvind?
So this is that of a discectomy.
Yes, whichever, whatever. So basically, just show us your video. We'll be loving to see how you dock your tube and what is the extent of your endpoint, like you spoke about, the endpoint in discectomy versus decompression. And then I'll show a quick one on my side.
Can you see the video?
You will have to start sharing. No, you'll have to start sharing from your thing.
One second.
Start sharing. So while Arvind is setting up, Ranjit, can I catch you on that? Anything else you would do while getting your tube docked in for a patient with decompression versus in a patient with TLIF? Where is your skin incision? How lateral from the midline?
So three things I consider apart from what always mentioned, like what Umesh mentioned, to see where is exactly the disc lying. Is it migrated up or down migrated, and where's the main quantum of stenosis? And is a facet hypertrophied? Is the spinous process curved or straight? Many times you find that spinous process is curved. There are times that you have got severe hypertrophic facets and your 18 mm tube might not go in. So you might have to go in for a 60 mm tube in those situations. If it is stenosis, I tend to go more lateral because I have to go over the top. And I have a pattern in which I see the actual MRI and see what is causing the stenosis. Is it flavum and disc, or is it only flavum? If it's only flavum, I go contralateral first and then come to ipsilateral. If it is disc, I do ipsi first, then I do contra. That's a way to decrease, because tight canals you take up, there is chance of dural tears. So if you do contra first, in case of flavum, you can decrease your chance of dural retraction and thus decrease your chance of dural tears. This was stenosis.
Right.
This very much straightforward right into the paracentral region.
Right. Arvind, we are still not able to see your screen. Would you like to start sharing your screen?
Trying to do that.
Yeah. Okay. Anyway, so if Bala, one quick answer from you. How do you ensure that the pars is not injured when you're doing ipsilateral decompression? What is your sequence of decompression? Do you do the contralateral first and in ipsilateral later, or you do ipsi first, contra later? And while you're doing this, how do you ensure that the pars on the same side is not injured?
So I think, again, it comes back to how you dock and where exactly you dock. So when you are docking, especially for an stenosis or a disc, you probably, if you are perfectly docked well on the pathology, you are going to not cause any injury to the pars. Then once you are in there, once you've docked it correctly, the next thing you look at is, as Ranjit very correctly mentioned, in a severe stenosis, I also do the contralateral first, and then I'll come to the ipsilateral. Whereas if it is a simple, straightforward disc is the main pathology with a little bit of stenosis on the opposite side, I would do a ipsilateral discectomy. So where do you stop and how far you go with your pars is your upcut. So your upcut is basically what you just keep on going. And you need to be able to, the first thing to do is to make sure you strap your patient, every single patient when you do an microdisc or decompression, any MIS, obese patient, thin patient, strap the patient nicely, because you want to be able to tilt your table and your microscope, the tilt table away and the microscope towards you to be able to see. So when you're going to use your microscope and your table in your advantage, so you're going to actually look into different corners within that tube. And if you don't do that, then you just keep on nibbling your bone and you'll enter into pars. Whereas if you are able to look into the corner, adjust your microscope and tilt the table, you're unlikely to go into the pars decompressing. And once you have to do ligamentous decompression. There's no point just doing bony decompression. Once you do ligamentous decompression, you're looking for the ipsi contralateral nerve root. So when you start looking at the contralateral nerve root, you do these maneuvers, then you will probably avoid pars damage.
Okay, understood. I think the point is very, very clearly taken, and we'll start seeing a video from here. The video is all about a microendoscopic decompression. I'll quickly run through it, and this video shows about the principles of tube docking. This is in a case where a patient of L4-5 canal stenosis, right more than left symptoms. So the tube is going to be docked from the right side. Arvind, can you tell us about what is over the top decompression? We heard Bala speaking about it. What is over the top decompression, and can you really decompress on the opposite side by just docking your tube on one side and do a decompression on the other side? Please highlight us.
Yeah, so the beauty of the spinal canal is such that it is in an axial section, it's like a triangle. So if you tilt your tube appropriately, it's not difficult to decompress the opposite side. Even when you decompress, do an open decompression, it is much more easier to decompress the contralateral side than the ipsilateral side. Some surgeons I've seen when they do an open decompression, they go on the other side to decompress the ipsilateral side. They go to the contralateral side once the contralateral decompression is done to do the ipsilateral side. So it's you do a laminotomy on one side, you do a ipsilateral decompression on that side, either initially or later on, and by drilling the base of the spinous process and the inner cortex of the lamina on the opposite side. So without exposing the spine on the opposite side, we can do a contralateral decompression. You can do a contralateral bony decompression as well as flavectomy, etc. to free the nerve root.
Right, and we are going to just see that exactly, and that's where the guide wire is coming under C-arm guidance. The guide wire is on the spinolaminar junction, spinolaminar line, L45, the tubes, dilators are coming over, and all this is done under C-arm guidance. We are seeing that the tubes of sequential dilation are going in. The length of the tube, what is the exact depth of the tube is known by the markings on these dilators. They are all gradually marketed. I mean, they have markings on it. And the depth in this particular case came up to be 50 millimeters. So we are using a 20 millimeter diameter, 50 millimeter length or depth of the tube, which is secured to the table with the help of this flexible arm. And that's the check. You can see how it is lined in the direction of the disc. That's how AP and lateral picture of the tube in place looks. The first view that we get is usually of some musculature that tries to creep in from the sides of the tube. This is the foot end. On the right side is the head end, the medial and the lateral. Mind you, the tube is at L45 on the right side. With the help of high-speed burr, you start burring at the base of the spinous process. So your most portion is the base of spinous process, where you start burring. Like Dr. Arvind mentioned, that we keep burring it till the level we get a release of the ligamentum flavum from the inferior edge of the upper lamina. And this continues to go on the opposite side. We mind you, this tube is still angled a bit, and we are going all the way to the opposite side. This burring is above the ligamentum flavum. So this is ligamentum flavum. You start here and go to the opposite side above the ligamentum flavum, calling it real above or over the top decompression. And this goes on till the other side of the facet joint. And once you release the ligamentum flavum on the other side, gradually with the help of nerve hook, you can further release it, and you can see a dural sac picture there. That's the beauty of a microscope, that on the opposite side, you can see absolute clear visualization of the dura, ligamentum flavum, fat can be made. And then bit by bit, piecemeal, you start removing the ligamentum flavum from the opposite side. Mind you, the burring goes all the way to the facet on the opposite side. The medial facet on the opposite side is done. And this continues till you are able to see the foramen, the foraminotomy on the opposite side is done. And this is a very patient thing to do, though the video gets over in 3 minutes. However, it takes really 30 to 40 minutes to complete this job after a tube is docked in. There are surgeons who do contralateral first and ipsilateral later, like me. And there are surgeons who do ipsilateral first and contralateral later. So that's the shoulder area of the nerve root. And you can really appreciate that there is absolutely no blood in the field. There is a clear demarcation of ligamentum flavum to the dural sac here. And you can see the lateral edge of the dural sac. You can actually go on into the lateral recess area and further lateral to it also. That's the lateral most part. Your nerve root can actually feel the disc on the opposite side. That's the disc on opposite side. And the foramen is very, very clear. The nerve root is decompressed clearly on the opposite side. And after you've seen the nerve root from shoulder all the way there, this is what you do. You get your dilator and try to move your tube to one or the other side. That's called wanding technique. You straighten your tube and do the same job on the ipsilateral side, doing piecemeal removal of ligamentum flavum, foraminotomy, keeping a close watch on the pars here and looking at the lateral edge of the dural sac. A bayoneted curved forward, which gives you a very undercutting done without taking the bone from above, comes very handy here. And this is the special instrument that comes very handy to all the surgeons. I would recommend everyone to invest into this. And you can see the lateral edge of the dural sac, and the disc can be clearly seen. If you have to perform a discectomy, a sequestrated disc material can easily come out from here. And we can do discectomy, stenosis, listhesis, anything with this. I'll not go into the details of this. And that's how a post-op MRI looks like. You can easily get complete decompressions. So this same thing can be extended to do an inferior facetectomy also. We have various indications for doing tubular fusions. We have various indications. We spoke about the indications of doing fusion in degen listhesis in patients with high grade or low grade listhesis as well. I have a small video about how to do a interbody fusion using a tubular technique. However, before that, we would like to go ahead with percutaneous pedicle screw fixation technique and tricks about it. So, Arvind, would you like to add to the decompression first before we jump into the PPF?
I think you have covered most of it. The only thing which I wanted to highlight is so the decompression it varies from level to level. If you're doing a L5 S1, it is not similar to L4-5. The L5 lamina is very wide, so the degree of angulation that you need to do, the degree of tilting you need to do of the table, etc., varies. And you know the lamina of L5 is very thin. There's hardly any cancellous bone, so there's just two blades of cortex, outer and inner, which kiss against each other. So it is very easy to get misled when you're doing a L5 S1. So I think there you need a lot of practice when you have to do L5 S1 decompression. Again, the disposition is such that there is sudden angulation, so you need to, raise your head end to make the L5 S1 level as horizontal as possible. Otherwise, you'll be operating in an extreme angle, which becomes very difficult.
Right, Bala, for multi-level decompressions, is your tube placement different than what it is usual? Like, for example, if you're doing 4-5 5S1 2-level decompression, will it be different than a usual tube placement?
No, what will be different compared to a single level is the location where I would initially dock, because I would dock it in between the two levels. For 2 levels, I don't use 2 separate incisions, I use a single incision. Though some people do recommend that even if you're doing 2 level, to use 2 separate small incisions adjacent, but they usually get interconnected, especially in the lumbar spine. So what I would do differently in terms of docking, one is I would still use an 22 millimeter port, but I would start probably a little bit more lateral. Because the angulation, as Arvind mentioned, one of the points between L4-5 and L5 S1 is slightly different, and usually the decompression is either 3-4, 4-5, or 5-1. So I would start a little bit more lateral so that I have that bandwidth to be able to go to 2 levels, and sometimes you can do through a single incision even up to 3 levels, especially if there's in lordosis. So I think it's not much different.
Yes, I think Ranjit, do you use fixed tubular retractors, or you use expandable ones for multi-level canal stenosis?
So if it is for stenosis and disc, it is a fixed tubular retractor. If it is for an MIS TLIF, expandable retractor.
Vishal Peshetiwar, what is the diameter of your tube usually for a single level versus multi-level versus a TLIF?
For a discectomy, it's usually 18 millimeters or 16, depending on the size of the patient. For a fusion, it's a 22 millimeter.
Right. And the usual length, I mean, is there anything specific in length that you keep ready with your
average? I have a full set, but majority of the times we use a size 5 or a 6. In obese patients, we have used up to 8. And I mean, very thin patients, I guess 4, 3 or 4.
Right. Arvind, any specific difficulties that you anticipate when you use a short tube versus a long tube while doing over-the-top decompression?
Sorry?
So when you use a long tube for obese patients for decompression versus when you use short tubes for thin patients, is there a difference in anticipation of problems that you may come across?
Yeah, short tubes, they keep coming out of the patient's back often. So if you're doing it in a very thin patient, you will not enjoy the surgery. If the patient's spinous pulse is easily felt, if you're using a tube which is 2 or 3 centimeters down there, it keeps coming out every time you work. That is the only difference.
And in a fat patient, don't you think the maneuvering of the instruments is a little difficult? And
so can I come in, Vishal?
Yes, please, Vishal.
Yeah, so I think the index length is 6. The moment you go beyond 6, size 6 tubes, then the bayonet instrumentation starts making a difference, because till 5 you're able to move your instruments because the tube is shorter, so you are able to move it much more outside. The moment your tube becomes big, the movement of the instrument becomes smaller, because the tube doesn't allow that instrument to move. One other thing, what happens is, uh, very few have MIS drills, the thin ones. Most of the institutions will have those fat, straight drills to work with. That's where the long tube becomes a problem. Also, in a long tube,
Right.
you need 9 inch long instruments to be able to reach there. So as the
Right.
patient
Very
gets
true. Very
fatter,
true.
your how to say, movement inside becomes lesser. You need to keep
Right.
wanting to reach different areas. So it's a better idea to
Right.
use a fixed tube in a fat patient, because you're able to maneuver it wherever you want without it opening up.
Right.
Unless you have a solid tube, a good quality. A quadrant is not a good quality tube to want. You need
Right.
to probably
Right.
have a Thompson or a Pedicle or Jesco tube to go there.
Right, right. I think we'll just move on quickly. We have another 20 minutes before we come back. So I'll just finish off this thing, the use of tube in doing a TLIF. We all know that tubes can be used in extensive fusions also. However, before we go and think about doing a fusion with the tube, you should have done enough number of decompression procedures. That's the paramount thing. The principles of TLIF, the target surgery, doesn't change, and that is why we must understand what a TLIF looks like. A TLIF is a transforaminal access to the foramen, and through that you reach the disc. You do a discectomy, prepare the end plates, and then do a fusion there by either graft or your cage. Usually it's always a cage in MIS TLIF. And the principle is that you remove this facet, as is marked here. This is the inferior facet there, and you remove the facet to see the traversing and the exiting nerve root. It is here in between the triangle between the exiting and the traversing nerve root where you do a discectomy, and then prepare your disc space and get your graft and your cage inside. Now we must remember that this site of excision of facet is different from your tube, which docks in more medially for decompression. And that's what Dr. Vishal Peshettiwar was highlighting, that your tube in a fusion should get docked on the facet, where you are able to see a bit of ligamentum flavum, a bit of lamina, and most of your facet. And your incision on the skin also should be like that, where you are able to get medialization of the cage placed, and the same incision can then be used for percutaneous pedicle screw instrumentation, which Dr. Vishal Peshettiwar is going to highlight us about. So how do we do that using a tube? I'll just go through quickly. It's a 3 to 5 centimeter lateral paramedian incision. Your tube goes in exactly like how we just saw, that your tube comes down there. You do an inferior facetectomy like it is seen in pictorial form here. You do a traversing nerve root decompression as you see here. You add a contralateral over the top decompression above the ligamentum flavum, and then remove your ligamentum flavum like you can see here in the pictorial forms. And both the nerve roots, ipsilateral and contralateral, are very well seen to you. It is then that you start doing your discectomy and fusion and prepare your disc space. And after that, I put my guide wires and screws in here. There are surgeons who do screws first, fusion later, where in my practice, I've been doing fusion first and guide wires later. Just to show you a small case scenario for a patient of L4-5 spondylolisthesis, where we are planning to do a MIS TLIF. I'll quickly rush through this. Putting a tube is the same. After your tube goes in, that's the medial side, that's the lateral side. This is on the right side. That's the superior edge, that's the inferior edge. And what you're seeing is the L4-5 joint clearly burned out. That's the spinolaminar junction where you start your first bite. There are surgeons who use osteotomes to do that inferior facetectomy. And there are surgeons who use fine forwards to get the bone out. The principles of releasing and decompression from here onwards remain the same. You remove the ligamentum flavum from superior edge. You do a ligamentum flavum release from the overhang of the superior facet of L5 or the inferior vertebrae, releasing the ligamentum flavum completely, medially, laterally, all the way into foramen. This is the area where it starts bleeding, so you get hemostasis there. You start seeing the edge of traversing nerve root. Completely remove the ligamentum flavum, do a foraminotomy, achieve good hemostasis. Put your patties, one in axilla here, one in the foramen and one in the traversing nerve root area. Mind you, this is the foot end. This is the right side is the head end. The top of screen is medial. And then you do a box cut of the annulus. And the procedure then is nothing but discectomy, preparation of end plates, getting your graft in there, doing pucca, preparing, grating it, putting a lot of graft there, and your cage then comes in. And you check it, get your tube out, do a contralateral decompression. It was a case of revision spine, so we did a contralateral later. And as you can see, complete decompression the opposite side, like we saw in over the top decompression the opposite side. You can see the nerve root. And that's the mobility of the nerve root. Further can be mobilized all the way. That's the disc on the opposite side. And the mobility of the nerve root was there. So the idea is that this tube docking is different when it comes to fusion. The site of tube docking is different. Your tube gets docked on the facet. The internal surgery remains the same. You do an inferior facet dissection. You take down the overhang of superior facet. You release the ligamentum flavum, do the discectomy, prepare the end plate, put a lot of graft in there, and then put in your cage there. There are certain concerns about MIS TLIF, whether the graft is enough or not, whether fusion is good enough or not, whether end plate preparation is good enough or not. Let me catch Dr. Bala. Bala, what is your take on whether the graft required to achieve optimum fusion is enough and available through MIS TLIF, or it remains less? Your voice, Bala.
Minute. Yeah, can you hear me? Yeah.
Yeah, Bala.
So
yes,
in majority of cases, I would say more than 90% of cases, the pathology usually has a larger facet. So when you're removing the facet, you have adequate bone, and when you do your foraminotomy, even if you're not going to go to the contralateral side, you still have enough bone to go into the space, and I have not had any problems. I have not used, very rarely I have used, unless you have a big patient, you have a large space where you feel that this may not be adequate. So I would say in 90% of the times, the bone that you remove from the facet joints and a little bit of the lamina that you take around is sufficient. But it's very important how you use it. If you are somebody who uses a drill, then yes, you need to probably think about what alternatives you have. So I use the drill very rarely, or I only use it, in a really tight stenosis when I'm doing contralateral decompression. But
right.
to remove the facet, collecting the facet, I use osteotome, the angled osteotome, and I save every bone. I do upcuts. I save all the bone.
Arvind, how differently do you do it? I mean, any special trick of getting good hemostasis, and if there is any different trick and tip that you may want to give for the delegates?
Hemostasis starts right from the beginning.
Arvind?
Yeah. Can you hear me?
Right.
So hemostasis.
Yes, clearly can hear you.
Yeah, hemostasis starts right from the beginning. So whenever we do either a discectomy, decompression, or a TLIF, so see, if you insert these dilators without infiltration, you'll see it bleeds like crazy. So there is sharp arterial bleed you will come across. So what I do is I infiltrate that area prior to beginning the surgery with about 15 to 20 cc of, just dilute saline. And that plus about bupivacaine, about 0.5% sensocaine of about 5 cc plus 15 cc of saline. So that makes two things. That helps in two ways. One is it gives preemptive analgesia. Second is it makes the whole thing very moist and soft. So when you put your dilators, there is very less bleeding. And second is when you are using the long cautery tip. So the other thing is you continue to bleed if your tube is shallowly docked. If your tube is docked shallow, you need to go deeper again once more so that you don't come across too much of soft tissue when you're, before you start your bony work.
Right.
And then, of course, use your burr.
Right. I think Arvind very, yes.
And, bone wax all
yes.
towards.
I think very aptly Arvind has mentioned. Very true. Very true. Very aptly, Arvind has mentioned that hemostasis starts right from the beginning, and using a good hemostatic meticulous measures to not only incision but pre-operatively giving saline also helps you get good tube placement, give you a good hemostasis, also pain control. Bala mentioned and highlighted about use of osteotomes to preserve the bone. We also know that getting a tube rightly placed is very important. Vishal, can you tell us about your incision? I mean, having an incision too medial to get your tube straight docked on the facet sometimes can have challenges of getting your screws which come from a lateral part. So how do you balance your placement of skin incision on the skin surface?
It doesn't matter if in a very fat patient, in fact, I would use a separate incision to put my screws through that, and that incision would, the screw placement would be more lateral than where my tube placement is. The whole idea in doing a TLIF is to dock your tube on the facet and the part exactly superior to it so that you are over the disc space where you want to do a fusion. As the patient gets fatter, your entry point will go laterally. But a lot of people use this. I also initially used to use the same incision that I use for a TLIF to put my screws in. Now I have changed. I make a small incision, do my TLIF through that, and I use 4 different percutaneous cuts to put my screws, because I put my screws way, way, way lateral. Using a O-arm gives me the advantage of knowing exactly how lateral I can go. Sometimes it's like 6-7 centimeters lateral to the midline. And that gives you actually a very long screw that starts at the outer edge of the facet, goes all the way in, does not get inside the pedicle's medial wall. And we have been using 50-55 size screws routinely in where we would otherwise have used 40 to 45 millimeter screws. So it looks weird where you have a incision for TLIF and then you have 4 screws going separately.
Right. So Ranjit, do you often use expandable tubes for doing a TLIF?
Yes.
Any specific reason for that?
Yeah, Vishal, see, if you see most of our L45, L5S1, when you take those 2 stabs to put the screw, they become a one incision. So instead of having that ragged one, like the thing you asked, how do you take your incision? On an AP X-ray, I measure my lateral pedicle border, and lateral pedicle border is where my tube goes in. That's my incision. So through it, I use expandable retractor. It makes life much more easier. Ultimately, if I use a tube and 2 stabs to put my screws, it becomes the length becomes same. It's same 25 millimeter.
Right. Neeraj, have you had a chance or a case where you have to do a bilateral facetectomy, or always you have been able to get away by doing only unilateral facetectomy? Or there are some instances where bilateral facetectomy becomes very important, not only for reduction, but also for fusion. Neeraj? I think Neeraj is gone. Neeraj, we can't hear you. I think we have lost the link with Neeraj. Arvind, any incidents where you have had to do a bilateral facetectomy, either for reduction, fusion, release, or decompression?
Can you hear me?
Hello?
Can you hear me, Vishal?
Yes, Neeraj, we can hear you. Please.
Okay, so I think it's a very pertinent question. I think whenever I do alpha S1, particularly whenever there is a collapsed disc, I think a chronically collapsed disc and alpha S1 you are doing, it's very important to restore good low doses at alpha S1. So if you want to give a better compression, good low doses, I think at alpha S1 level, my technique, I generally always do bilateral facetectomy. L4-5, I think majority of the cases we can go without doing bilateral facetectomies. So except, when you want to give a significant low doses on compression, I think, you should do a bilateral facetectomy. Otherwise, in most cases, you can get away with unilateral facetectomy.
Right. Bala, in cases with very severe facetal arthropathy, would you like to do a unilateral facetectomy, or you like to do a bilateral tube docking and bilateral release?
Yeah, so in two reasons why I would do a bilateral, and I've done that very few times. One is if you have more than a grade 2 listhesis, a grade 2 to grade 3, and usually more than grade 3 I wouldn't do, but a grade 2 listhesis or more, and the disc space is completely almost collapsed. It's just a very small disc, and also if the bone quality is not very good. So otherwise, especially the first two things which I said, collapsed disc, large facets, and a grade 2 listhesis. If you want to achieve lordosis and correction, you have to do this. And also, if there is an severe osteoporotic bone, you're putting a lot of pressure on that, the screws. And so I think, bilateral release will just free up things.
Right. Agreed. I think, Umesh, any quick comments on this? When would you like to do a ipsilateral facet release first? Or when would you like to do a implantation, pedicle screw instrumentation first, and then the fusion work later?
Well,
Your
almost
sequence of events.
So now that we are using navigation, so almost most of the times we are putting in our guide wires first. We are not putting in the screws. Now the only decision making comes when we are dealing with the grade 2 or high listhesis, as Dr. Bala was mentioning. So in those cases, we still don't put the screws in the beginning. So, and then we do an ipsilateral facetectomy, discectomy, and we see the play between the bones after doing a disc work. So if there is a good play between the bones, and there is a good chance that we are able to reduce by just an ipsilateral facetectomy and disc release, so that is enough. Then we put the screws on the other side because guide wires are already in place, and then you can just put in your rest of the job, prepare the disc space and put in a cage from here while reducing.
I think message is very clear. It is very subjective and surgeon based. However, in patients with high grade spondylolisthesis or grade 2 plus, Arvind, do you have any other method of doing it? Like, how do you aid your reduction? Do you do disc work first, release work first, facetectomy first, or you get your screws first and reduce on the screws? Arvind, your voice.
For yes. Grade 1 and grade 2 lytic listhesis is very simple. As you will be surprised, as soon as the patient is positioned, you will get sometimes complete reduction. If it is resistant to be reduced, what I do is I put screws on the contralateral side of the symptoms, and I do then put the tube on the ipsilateral side. I do a facetectomy, discectomy. I try to put in shavers and open it up, and then I distract on the opposite side as much as I can. It's very important that you have a good purchase of your screws. If you don't have good purchase of your screws in L5, S1, you're doomed to fail. So it's very important that you put the longest screw in the best trajectory that is possible. You need to struggle to put these screws. And if the patient is osteoporotic, then you need to augment it with cement, use fenestrated screws, etc. Try to make your fixation as strong as possible. And sometimes, in the beginners, they do not understand that it is so important to get your S1 purchase at the tricortical area. So if you don't have a good S1 purchase, you're doomed to fail. So unless you have good purchase, you can't do all these maneuvers. So you distract on the opposite side. Then you put a cage on the ipsilateral side as big as possible, so that also helps in lifting your disc, your L5 up, and that also gives some degree of reduction. And try to use a non-sextant kind of a mechanism here when you're doing L5 S1 reduction, because here the rod goes on top of the screw. When you use the sextant mechanism, you can't pull it much. So use somewhere wherein there is a reduction maneuver kind of a mechanism, wherein the screw can be pulled back. So this kind of mechanism helps in getting some more reduction. And once you do that on the opposite side, you do the same thing on the ipsilateral side. And so whenever I've gone on the opposite side, it is when I've seen that my cage is far lateral on this side and it is not reached center or gone beyond the opposite side. Then I put another cage from that side. But it's very rare, maybe 3 or 4 times. And the other situation where I would suggest people to put 2 cages, go from 2 sides, is when there is discitis. So when there is discitis, it is not the cortex, the end plates are gone, and it becomes it is a rocky situation. You need to really fill the entire surface area with the cage. Otherwise, the patient will have considerable amount of back pain.
Right. I think very pertinent tips about when to do bilateral facetectomy from Bala, Umesh, and Arvind. Now, once you have did decompression, your tube is in, you have did a good wide decompression, you have did good discectomy, you have prepared the end plates, whether you on one side or both sides, you have gotten your cages inside, you have gotten your graft inside, and now you are ready to get your screws in. You may do these screws before you do these release and fusion maneuvers like Umesh does it, or you can do the way I do it, where you do interbody work first and then get your screws in later. How to do a good percutaneous pedicle screw fixation is just imperative to the success of MIS TLIF, because the problems are not only when you get your tubes misplaced. The problems are bigger when you get your guide wires for the screws misplaced, when your screws are not placed well. If your guide wire slips, you can have a vessel injury, you can have a dural injury. If your screws are not placed well, they can have a lateral bypass, or they can have a medial perforation, again have a disastrous situation. If your screw hold is not good, it can get just loosened. If your screw is too strong, you are going too medially, you can actually injure the superior facet. Violation can happen, resulting into more ASD. So how to get the best placement and intraosseous placement of a screw in a percutaneous manner? None other than Dr. Vishal Peshetiwar. Dr. Vishal, over to you, please.
Can you see the screen?
Yes, we can see your slides, please.
Yes. So, I mean, if you're going to do a percutaneous screw fixation, you need a good quality CM. If you don't have, don't do an MIS surgery. You need an even better trained technician, because if your technician doesn't know how to show you well, it's a good CM is useless. A good quality table so that the radiation damage to the team is less. And of course, you should use proper radiation protection equipment. All of you should invest in a wrap around bismuth gown. You should have a thyroid shield that you should wear all the time, and you should have radiation protection goggles, because sterility is the last of the problems. You'll probably die of a thyroid CA or a bone marrow malignancy before you go sterile with radiation. So be careful with radiation there. Of course, you can use landmarks while passing screws. A lot of people use it very well. The biggest advantage of this is that you don't have to spend large amount of money for percutaneous screws. While passing a screw, you have to remember this route. What you're seeing here is the one we all try to preserve and try to put an optimal screw. This also the open as well as the MIS cases. In a minimal access surgery, if you were to take the pedicle as a face of a clock, your entry should be in the outer and just touching the bisector of the upper and lower quadrant. This prevents the reason to a lot of people say, why here and why not go a little superior? You will avoid the roots completely. But if you go above, your tulip is going to sit on the facet joint. And the moment that happens, you're going to get adjacent level disease. One. Second, you're also going to get a lot of post-operative pain in the patient because the facet of the superior level is going to be irritated. Well, all of us have done vertebroplasties. It's very similar to doing that. The trajectory. Now, if this is where the skin is, and if you take your incision here, this is the pedicle outer side. This is where on a C-arm, you'll mark the outer edge of the pedicle. If you start there, you are going to go inside the canal. So you should start a little laterally. Go at least 2 to 3 centimeters lateral to the outer edge of the pedicle as seen in the C-arm to get a good trajectory rather than starting right over that. This prevents a lot of problem, because if you take your incision right over there, then you have to pull the skin, put it in, it becomes messy. This is the trajectory you're looking at, not this. Well, while you're putting the Jamshedi, this is the medial border of the pedicle, and that's the base. So this needle should have gone through the base of the pedicle into the body before it crosses the medial border. This is the single most important step that you have to remember while putting a percutaneous pedicle screw. This ensures that the Jamshedi is inside the pedicle and not in the canal. Once this is done, you have to put in a guide wire. If there's one single thing that can give you a big problem in passing a screw, it's going to be the guide wire. So be very, very wary of this guide wire. This images are from a case that was done more than 10 years back. I no longer use pointed guide wires. I use blunt threaded guide wires because it prevents them from migrating forward. Never put it beyond halfway mark of the vertebral body. So there is some space for the guide wire to travel in case your alignment of your instruments is not in the direction of the guide wire while you're passing it. Tack this is again, we used to tap right up to the tip. I would now tap only up to the base of the pedicle and let the screw, most of the screws we get are now self-drilling. So they will let the screw find its path in the soft vertebral body. This is a small video. This hemostat is on the medial border. So my incision is 2.5 centimeters lateral to it. This is opening up the muscle. I used to feel the tip of the transverse process there and then put in the Jamshedi. You can see the Jamshedi going somewhere just above the 3 o'clock position. Once it is tapped in, the base of the pedicle has been crossed and it is still inside. Then I put in the guide wire. Once the guide wire is in, check at every step, at least in the initial part, so that you don't make a mistake. Overconfidence is something that will take us all down. Dilate the muscle over the wire. If you directly tap, I've seen a lot of people doing that, you end up damaging the muscle more and defeats the purpose of doing a minimal access surgery. Initially, at least ensure that your last dilator is sitting over the pedicle. Always hold the guide wire when you're advancing your tap, because there's a chance that if there is a little bit of bend at this junction, the guide wire might go in along with this and end up hurting the anterior structures. This is max I would tap just up to the base of the pedicle. This is, like I said, a 10-year-old video. So sorry for that. While taking it out, be careful that the wire doesn't come out. Putting it is again another extra 10-15 minutes there. Once the guide wire is out, put in your screw. In our zeal to keep the incision small, we forget that the tube, the candle of the screw is going to be a little bigger. There's a big chance it will put your adhesive drape inside and then creating a lot of problems. So better to take a little larger incision. Take the guide wire out once the screw has passed the pedicle. This is the problem I was talking about. Try to keep incision a little big so that it goes in and the skin edges don't get macerated. Sit your screw right where it should be. This is again to go in. Try and keep the screw head level. The reason to do this is because your rod will be easier to put in. These are the steps. Remember, in lateral plane, each one is at a different angle. It is always wiser to take a lateral X-ray on table to check that the alignment of the vertebrae, to check the alignment of the vertebrae. Also, you have to understand that not each pedicle is aligned at the same. As you go lower, the angulation of the pedicle is going to change. You have to keep that in mind while passing the guide wire in. When you're doing multiple levels, like in this case, mark your skin with straight lines and try to put all your screws in that one straight line, so that passage of the rod is easy when it's straight. If this hole was here, it is impossible to put an S-shaped rod going that way. So you can put in multiple levels, but you have to remember that you should have your rod bent to the shape of the spine that you're going to go in for. Navigation is very useful. It tells us the trajectory. It shows us the length of the optimal length of the screw, the optimal thickness of the screw you can put in, and the final seating. It also records position. This is very important in scoliosis to have the screw positions noted. I use an O-arm. This is how we acquire our image. Once the image is acquired, it is fed into the navigation there. The surgery happens with you looking at the screen rather than at the patient. I'll just take you through this. How does navigation help? So that's this is the image on the navigation, but this is what I'm doing. Once you keep it there, it will show you the optimal track. So you make your markings of where you want to get in on the skin. Once these markings are done, take the incision, and this is the real, I try to correlate both of them. As you put your guide, Jamshedi in, the navigation will show where you are. You seat your Jamshedi needle where you want to start. Then you do a measurement of the length of the screw that you will be able to put in by reducing this yellow thing is the tracker, the blue thing is the Jamshedi. So you know exact length of the screw that you're going to put in. Then you just hammer it in. As it goes in, you see the advancement on your navigation screen, so you know exactly where you're going. Once this is done, you can see the taps and the screw going in. That saves you a lot of radiation. It tells you more accurately where you're going. And of course, like Arvind was talking about a good S1 purchase. When you're taking an S1 screw, it has to purchase. This is a very high grade synthesis we are doing. This video is actually what we do here is then this is an awl, is a straight lumber sharp awl that I'm using and gradually advancing it further. So this, once it breaks through the anterior cortex, you know exactly the length you've gone in. So you know the exact size of the screw that is going to go in. And as you can see, this is sclerosed here and it's osteoporotic here. If you try to just ram the screw in, this screw is never going to get its purchase here. So it's always better to get the anterior tip there. Always use a mallet rather than your hands. It prevents plunging. A mallet is a very measured hit on the jamshedi, so it will go in only that much inside. Always check it. When in doubt, please check in a Siam. Beware of the guide wire. It is something that will give you grief if you don't look after yourself. Mark your landmarks on the skin so that you know where you're going. Align your screws in multiple levels. Take your time. Collaborate with someone. Thank you. So Vishal, that's all I have.
I'm going to share across. So Bala, what is your trick to ensure that your guide wire doesn't slip from your hand? Like, how do you make sure that
Sorry, the
guide wire
guide
problems
wire
don't
doesn't-
come to you?
Yeah, so I think, Vishal had very beautifully mentioned all the things that can go wrong. So just a couple of more points to add. One is, the things that can go wrong is right at the beginning. Your jamshedi needle, how you position, starting from either the 9 o'clock position or the 3 o'clock position, going inside. Once you get it, that sometimes is usually a little bit easier, or it may not be a major problem when you start doing more and more. But some of the places where you actually kind of get careless is when you are actually hello so you get a little bit careless is when you are actually changing between guide wire, jamshedi to your taps and putting your screw. And this is where I feel more and more of seniors should be careful when they are just letting their assistants do it, and we are watching. And if just one small step that you do incorrectly, your guide wire can go in and it can cause problems. And also, whether you're using navigation or you're using a C-arm, double checking between AP and lateral is so very important. And these are some of the tips that I would say. So accurate placement of the K-wire is so crucial to this operation, because either you will end up having a neurological deficit from the nerve root, or at the same time also removing, just make sure that the tips of your guide wire is not bent. Because if your tip of your guide wire is bent and you go all the way down with your tap, and when you take it out, you are either going to pull out the K wire is going to come out with the tap. And so it's very important, and make sure you don't use the sharp edge of the K wire, use the blunt edge of the K wire. So I think, all the other things have been covered.
Vishal.
Neurosurgeon at Bangalore.
Hello? Hello?
Yes, Gururaj, yes, I can hear you.
Yeah, Vishal. So the one more thing is to be very careful not to bend the guide wire. So you have to be always in collinear with the guide wire whenever you are putting your tap into it. If you bend it, invariably it drives through or it comes out. So the one is to be very collinear with your guide wire.
Right, very true, very true. What else other than Neeraj? Neeraj, any quick tip on how to prevent implant-related problems? Neeraj?
Neeraj has gone to do the cooking.
Umesh,
No.
please tell us.
Yeah, I'm here only.
So quick tips, Umesh and Neeraj, one quick tip each on how to prevent problems related to guide wire and implant.
One is under see, I don't have a navigation with me. So I mean, when you are doing a fluoroscopic guide wire insertion, one of the most important thing is in a lateral view, your tip of guide wire should hit on the anterior cortex, because if it is not hitting the anterior cortex, still I mean, when it hits the cortex and in lateral view your guide wire is not at the anterior border, then there are high chance that your screw might go laterally, not into the proper angulation medially, and you may actually wire a lateral cortex and may lose the strength of your hold also.
Right. Umesh, what are your concerns when you do an MIS TLIF? No procedure is foolproof. Every procedure has its own downsides. Can you please highlight downsides of MIS TLIF? Only downsides. We are not talking about complications. We are not talking about anything else, but downsides that MIS TLIF falls short to achieve, and there are better procedures available to achieve those.
Yeah, so if you like nowadays, because of all this sagittal balance and all, so only place where MIS TLIF falls short of probably an open procedure is in restoring adequate lordosis, and that is something that Dr. Ranjit was also mentioning, that is why he uses an expandable cage, a expandable TLIF cage with in order to expand the anterior portion and then compress it from behind so as to achieve adequate lordosis. And that is why, other point also was being mentioned, that bilateral facetectomy is probably sometimes required in order to do what we nowadays call as a cantilever TLIF, or something that is used for restoring lordosis in these cases. So I think the downside of MIS TLIF as compared to an open TLIF probably somewhere is in restoring the lordosis. Otherwise, all the disadvantages and contraindications we have already considered. But apart from that, I don't see any major.
Right, Ayush, we know that you do a lot of OLIF procedures, and you consider that this very downside of MIS TLIF can be taken care by OLIF. We'll probably not be discussing OLIF today. We are falling short of time. We'll have a separate session on anterior procedures, OLIF, DLIF, and XLIF. And you being the master, we'll surely have you as the panelist on there. But in a brief, can you tell us about what is OLIF and how does it takes control of the problem that Umesh just mentioned?
So the best part of OLIF is that it is an anterior procedure. We all understand that when you go and no matter what you do with posterior, you cannot get that lordosis, what earlier people have told, right? The other thing, that the footprint of OLIF is really big. So what it had, because of the footprint, if you see the TLIF, no matter what you do, the amount of discectomy which you can do from posterior is limited. If you see the literature, maybe not more than 50 to 60% of discectomy you can do. But again, if you go anterior, you can do a pretty good amount of discectomy. Again, the footprint is so good that it goes from end to end, and that itself gives you the power, more power than what you will get with TLIF. Either to get the lordosis, even it can derotate the spine, especially in a degenerate spine. It has the power to derotate it just because you get a good lordosis, and because of the footprint, it is a strong device. So whenever you feel that your TLIF is falling short, that is where the OLIFs comes in. It gives you more buck for your money, and it gives you more than what your TLIF will give in terms of getting your sagittal and coronal balance. That is how I still, MIS TLIF remains my workhorse. But when I want to do more than just a TLIF will offer me, and that are the cases where we talk about degenerative scoliosis, or maybe a adjacent segment disease and things like that. That is where I think OLIF has a role, and the indications are growing as we.
Thank you, Ayush, for bringing up that thing. Ranjit, before we go ahead, before we take part from the day, does cost-intensive nature of MIS surgery worries you? Isn't it that you think that it's a resource-intensive thing for it to percolate to the poor population of India, and India still struggling with the cost of the surgeries? Don't you think this is further going to be a major hindrance? Other than that, I feel skill sets. I think we are all still struggling to evolve into better MIS surgeons. Your final comments on that, Ranjit, before we part off.
Not at all.
And how do we deal with this?
I don't think that cost is an issue right now. We have got almost every MIS equipment and implant is locally available by multiple companies, which is not really very expensive as compared to regular implants. I don't think cost is a factor, number one. Number two, skill set. Yes, we have enough and more workshops and mentors available right now to learn it. Number three, learning curve. Yes, you have a learning curve. We all want to perfect each day. That's why we are learning more. We are having webinars and workshops. So definitely it is all like what you said, the conviction to do it. You want to do, you want to edge it better.
Right.
That's what is required.
Right. Right. Umesh, one last question. I think I would surely want to give this a full session of effects of radiation and the problems of radiation in MIS surgery. We all know that MIS surgeries are all radiation dependent. They are all fully CM guided. Are you not worried about more and more young guys taking up MIS surgery and radiation being a big deal, creating problems for future generations to come? We all know that radiation is known to create infertility. Malignancies, radiation-induced malignancies among MIS surgeons is on rise to the tune of 11% in cardiologists, MIS surgeons. It's been reported in literature. So what's your take on that? And how do you prevent the effects of radiation on the operating surgeons per se?
Well, Vishal, you already summarized, what is the effect that radiation is having on us. It's a huge problem, and probably at least I have not paid too much attention to it in my early days, and that is some mistake that the other young people should not be doing. And the only way, see, MIS is here to stay, and we cannot take away this technique just because of radiation exposure. And the only way we can circumvent this is by involving navigation. So navigation is the answer to radiation exposures in MIS surgery, because it is wrong for us to tell, okay, I am not going to do MIS surgery just because radiation exposure is high. The only way we can circumvent this is by including navigation.
But Umesh, it makes it even further resource intensive.
Yes.
Other than navigation, what are the day-to-day measures to reduce radiation effects?
So there are a lot of day-to-day precautions that we have to take, despite whatever other methods that we are going to use. So like proper protective gear we have to wear, and most of us do not wear a thyroid collar, and that is very, very important. And actually that is the most important thing that we have to wear, even for a simple procedure. Even if you think that there is only going to be like 2 or 3 exposures in a case, wearing thyroid collar is a must. Most of us do not use a radiation goggle, so because cataracts are very, very common in all these radiation side effects, and radiation goggles we have to use. And of course, whenever our hand is going to come in the way, because most of the times in MIS, our hand is there right in the, especially in an AP view, our hand is there right, putting, holding the Jamshedi needle, and we are telling, okay, take a shot. So that is something that we should avoid. We should always use a long instrument in order to hold the Jamshedi in place. And if we are not able to do that, we have radiation protection gloves that are available. We have to use those radiation protection gloves. They are not very expensive. You can reuse them, unlike what it has been told. So we have to use those radiation protection gloves. Apart from that, we have to take, whenever it is not required for us to be in the operative field, we have to be away. We have to make sure that the amplifier is on the other end of the operating surgeon, mainly because that is where the most of the scatter radiation comes. So these are all small things, and there's definitely a lot of things that we can do to prevent radiation exposure. And as our experience in doing MIS procedure goes, there are a lot of shortcuts that are available, even while putting a percutaneous pedicle screws, where we don't have to take AP and lateral like 3 to 4 times in order to put one screw. So again, we can minimize the number of shots that we can done. We can tell the radiation technician to use the minimum amount of dose that is required for us to take probably a good image, rather than taking a prolonged shot every time that he is pressing the button. So these are some of the things that we can do. And as you have told, there are, it requires,
yeah, I think thank you, Umesh, for bringing forward some really important point for all the young guys who are listening to this webinar. And I'm sure from here, many more would want to become MIS surgeons. But the most important thing is that this is the age that you may want to take care of yourself. And being a surgeon is good. Being a MIS surgeon is even better. However, being a safe surgeon is better than being just a good MIS surgeon. And there are ways and means to reduce the effects of these radiation. You really don't want to have a malignancy just by becoming a good MIS surgeon. And there are ways and means to protect yourself from the downsides of MIS. Of course, the safety of surgery is very important, but the safety of surgeon is also paramount, so that the surgery doesn't earn a bad name. So before we end, I would like to thank all the panelists. Dr. Ayush, really appreciate you being around and sparing time. Umesh, Ranjit, Bala, Guru, Neeraj, Really appreciate you being around and have insights on percutaneous pedicle screw insertion and also navigation and arm technique. Arvind, thank you so much for sparing your time. So before we take part, the summary here, we started this day with the principles of MIS surgery. We spoke about various types of MIS surgery. We are all now discussed and we have established the goals of achieving the end point of outcome in various indications for spine surgery in MIS. We also know when not to touch or which patients you may regret doing a MIS surgery, and also what consent has to be taken in MIS patients. We all know that there is a specific learning curve involved in MIS surgery, and it is the most challenging part, which patient to start with and where to head for, and when to have a change of gear from simple cases to advanced cases. That's the learning curve that in the initial cases, we know that nerve handling dural tears are a problem. However, these are concerns that coming to your mind is a genuine concern. However, they can really be overcome in first few cases, and attending more workshops, more webinars, more understanding with one-on-one with faculty is going to reduce your learning curve overall to get a safer result in long term. The armamentarium to start MIS surgery ranges right from microscope to long cautery tips to good burr to tubes to various implant system to various new instruments, and getting used to these instruments is something that is very, very important. We all know how to do a microdiscectomy. We all have just learned about tubular microendoscopic decompression. The tricks and tips of MIS TLIF was discussed with all the panelists here. We heard Dr. Vishal Peshetti was speaking about the principles of intraosseous placement of percutaneous pedicle screw and the concerns and problems of guide wires, tube docking, principles of guide wire saving, principles of guide wire and tube docking were discussed in great detail. We also discussed about superior facet violation, concerns of fusion, saving of a lot of bone graft, and of course the problem of radiation in MIS surgery was discussed along with the prevention modalities in these patients. I hope and wish that you all have had an enriching and enlightening session here. We hope to have a second session about problems in salvage in MIS surgery, apart from the newer technique of OLIF, DLIF, and XLIF in coming sessions on MIS surgery. Thank you so much for joining us, all the panelists. Tomorrow we are going to have a session on cervical myelopathy by Dr. Mihir Bapat, Kshitij, and Dr. Sandeep Sonone, where Dr. Bala, Dr. Neeraj, Dr. Umesh, Dr. Ayush, and all are going to be our expert panel as well. And I'm sure tomorrow we'll change gears from lumbar spine to cervical spine and have another experience to be happy about. Thank you so much for joining, all of you.
Thanks, Vishal. Vishal, just the important point is that, important technique we all have to follow is make sure that we do all the cooking, cleaning, washing, everything very carefully. Otherwise, you won't be able to do proper MIS TLIFs. Yeah. So, guys, take care and thank you very much.
Sure. Thank you so much. Thank you,
Thank
Umesh.
you,
Thank you, everyone.
Thank you. Bye bye.
Okay. Bye.
Bye, Bala.
Bye, Umesh.
Bye, guys.
Bye bye. Bye, guys.